And as usual, we'll just go through the question, you put your answer down, and then we will look at the rationale. And any questions, you can always still post them, and we'll try to answer them. All right. All right, let's try to get the live up to 1,000 likes to start. You know, I'm not really that needy, right? All right, so we'll just start with 1,000 likes, and then from there, let me just finish set up this. Jackie Fablin, thank you for liking up the live. Empress Jenny, thank you for tuning in and liking up. All right, Shayna Williams. All right. All right, thank you so much. All right, so the first question. So how am I supposed to, so the first question, a patient with chronic kidney disease has a serum potassium with 6.2 milliequivalent. Which action should the nurse take first? A, administer furosemide. Do I still need to read it? I feel as though I still need to read it because it's going to be a little bit more interactive. How do I normally do it? Because if I just sit down and wait for you guys to choose, then it's going to sound boring. And we need a little bit of a vibe and energy with the class. All right, so BB, okay, which is place the patient on the cardiac monitor. Okay, all right, so the answer is A, administer furosemide. B, place the patient on cardiac monitor, restrict dietary potassium, notify the provider. All right, so the answer is actually B. Why you want to place a patient on the cardiac monitor though? Why are you placing the patient on the cardiac monitor? Because of the risk for arrhythmias. All right, so you're placing the patient on the cardiac monitor because of hyperkalemia and the dysrhythmias that can arise. So hyperkalemia can cause life-threatening cardiac arrhythmias. Continuous cardiac monitoring is priority to detect changes before interventions like medications or dietary restrictions are implemented. What are one way or two ways you can actually treat your hyperkalemia? Give me a few medications that you can use to treat your hyperkalemia. How do we normally treat hyperkalemia? Insulin, okay. What else? Why do we give the patient insulin? How is it gonna work? Asante. Yes, insulin, calcium gluconate. Okay, nice. So the calcium is going to protect the heart. The insulin is going to help with the transfer of that potassium there. Ketoxalate definitely is going to give them the diarrhea to help with removing some of that potassium. Good. All right. All right. A patient with congestive heart failure reports increasing shortness of breath and edema. Which lab value should the nurse review first? A, hemoglobin, B, BNP, C, serum creatinine, D, liver function tests. So a patient has congestive heart failure. Which lab value? Let me pull this down. Which lab value are you going to review first? Hi, Blue Drake. Thank you for tuning in. Yes, I am. All right. Remember to go ahead and follow. All right. So you have a patient that has congestive heart failure. They're reporting shortness of breath and they have edema. Which lab value are you more concerned about? Is it the hemoglobin, the BNP, the serum creatinine, or the liver function of that patient? Remember to tap up the live. All right. Hi, Prop says B, which is a BNP. Do we have anybody else on YT who has anything to add to that question? Yes, Shayna, we'll go for the BNP because that one is specific for your heart failure. So BNP is released when you have response, when there is a response to ventricular stretching and fluid overload, making it a key marker for worsening heart failure. All right. Hemoglobin, hemoglobin is there. Serum creatinine, we usually one of those markers for your kidney. All right, your kidney function, or just to tell how bad your kidney is. Your liver functions usually for your what patients? So your liver function for your liver patients, you know. So you talk about your you can look at your patients that are on cholesterol. Look at the ALT, yes, your ALT, AST, all of those. All right. So we definitely will look for your BNP for those patients for your heart failure. A nurse is caring for a diabetic patient. Which intervention is highest priority? So you have a patient that has DKA, diabetic ketoacidosis, which is highest priority for you. Administer IV insulin, monitor urine output. C, encourage oral fluids. Or D, provide patient education. So you have a patient that has DKA. What intervention is highest priority? Is it A, administer IV insulin, B, monitor urine output, C, encourage oral fluids, D, provide patient education? Shayna says A, administer IV insulin. Do we have anyone else? Chinona says C, encourage oral fluids. All right, Frank says A, good. Chinoma, why do you say C to administer to encourage oral fluids? A, nice. Yes, so the answer is A, administer IV insulin. Is DKA an emergency or not? Sorry, is a mistake. Okay, cool. All right. So insulin therapy is very, very important for your DKA patients. All right. So insulin therapy is critical to reverse your DKA by lowering blood glucose and stopping ketone production. Other interventions are important but secondary to correcting the metabolic imbalance. All right, what in terms of the ABG, nice Asante, it's an emergency. In terms of your ABG, what imbalance are you looking at? Is this patient gonna be in acidosis, alkalosis? What ABG imbalance you're looking at for this patient? Metabolic acidosis, definitely. All right, so you'll do your IV insulin. Which of the diabetic patients usually have usually go in DKA, type 1 or type 2? Metabolic acidosis, yes, definitely. All right. So you have a patient that is going to be getting insulin. So you have a DKA patient that is going to be getting the insulin. What are some lab values that you're more concerned about for this patient? So you have this patient that you're going to be giving insulin. You know the glucose is elevated. What is it that you are checking in terms of the lab values before administering your insulin? Anyone on YT? Thank you so much. Definitely you want to look at your potassium to make sure your potassium is normal. What number are you looking for in terms of your potassium? What's the range for normal potassium? Yes, Asante, Toya. So you want your potassium to be anywhere between 3.5 and 5 before you start administering your insulin. All right, because we know what insulin does with your potassium level. All right. So, okay, nice. Which action demonstrates proper technique when administering a subcutaneous injection? So which action demonstrates proper technique when administering a subcutaneous injection? Insert the needle at 45 to 90 degrees angle, depending on the patient's adipose tissue. A. B. Aspirate before injecting medication. C. Massage the site vigorously after injection. Or D. Use a 2-inch needle. Chinema or Chima says A. Shayna says A. All right. So inserting at 45 to 90 degree angle. Yes. What when we're administering for in IM, your intramuscular, what degree angle do we go at? We go the 90 degree. All right. So you'll go with your 45 degree angle for your subcutaneous, depending on the patient's body fat. Aspirating is no longer recommended for most medications and vigorous massage can alter absorption. All right. Thank you for the follow. All right, nice. A patient is receiving morphine via PCA pump. Which assessment finding requires immediate intervention? So you have a patient that is getting morphine via PCA pump. Which assessment finding requires intervention, immediate intervention? Is it A, the respiratory rate of 8, B, nausea and vomiting, C, mild sedation, D, constipation? All right, D, why are you concerned about the respiration of 8? Yes, I see you guys says the respiratory rate of 8. Why are you concerned about it? Overdose, respiratory depression, definitely Tia. All right, so you have that patient that is getting morphine. You're more concerned about respiratory depression. So if the patient is already at a respiratory rate of 8, you're gonna further cause depression, you know, in terms of their respiration. How would you go about reversing that? If you go ahead and administer the morphine, how would you go ahead and reverse, you know, your morphine, your opiate? What medication will you be getting for your reversal? Your Narcan, definitely. All right, so the respiratory rate of 8 is what you'll be concerned about with your patient that is on morphine because of the respiratory depression. So any rate that is below 10 is a medical emergency requiring prompt intervention to prevent hypoxia. All right, nausea and vomiting, you know, mild sedation, constipation, yeah, you'll monitor those, but it's not that, you know, important for your PCA pump, all right, or your morphine. A patient with newly diagnosed type 1 diabetes asks why insulin is required when they feel fine. What is the best response? A, insulin is needed because your body cannot produce enough to control blood sugar. B, you may not need insulin for long. C, diet alone can control your blood sugar. Or D, exercise is a substitute for insulin. So you have a patient that has type 1 diabetes. We have AAA, which is insulin is needed because your body cannot produce enough to control blood sugar. Definitely. You may not need insulin for long. Is this going to be a short-term or long-term thing for them? My insulin. It's going to be. So it's going to be a long-term, lifetime. All right. Diet alone cannot control your blood sugar, which is true. The exercise is a substitute for insulin. All right. No, that's wrong. All right. What are some signs and symptoms of a patient that is is diabetic? What are the classic signs of a patient with diabetes? What are the classic? Polyuria, excessive hunger, definitely thirst. Polyuria, polydipsia, polyphagia. Okay, nice. All right, peas a lot. Yes. Yes, definitely. Correct. All right. So insulin is needed because your body cannot produce enough to control blood sugar. Type 1 diabetes involves autoimmune destruction of pancreatic beta cells, making insulin essential for glucose regulation regardless of symptoms. All right. A patient with COPD develops sudden shortness of breath and pleuritic chest pain. Which intervention should the nurse perform first? And weight loss too, definitely Beyonce. All right. So the patient has COPD, develops sudden shortness of breath and pleuritic chest pain. Which intervention should the nurse perform first? A, administer oxygen via nasal cannula. B, notify the provider. C, obtain a chest x-ray. D, assess vitals and lung sounds. So you have a patient that has COPD. We have AAA, which is administer oxygen via. All right, always remember. So let's look at this one. So the answer is D, assess vital signs and lung sounds. All right, I think D, because we want to relieve the shortness of breath. Yeah, you definitely want to relieve the shortness of breath, but then look at the other option. Always start with your assessment or your ADPI. So always look at airway, breathing, circulation. Always look for your nursing process, and then from there. So always think about assessing your patient first, and then from there you go along. All right. So if you look through the options on the exam and there is nothing related to, the nursing process, then always go to your airway, breathing, circulation. All right. But if you see both of them there, always start with assessing and then you go down with your interventions. All right. So you'll want to go ahead and assess the vital signs and the lung sounds. So initial assessment helps determine the severity of the respiratory compromise, guides interventions, and identifies life-threatening complications such as pneumothorax. All right. So you definitely will end up giving this patient some oxygen. You'll notify the provider, get their chest x-ray. But before you start, this is what you'll have to do. You'll have to assess the vital signs and the lung sounds. All right. A patient with heart failure is prescribed furosemide. Which electrolyte imbalance should the nurse monitor for? Thank you for the fancy thing there. The level up. Fire. A patient with heart failure is prescribed furosemide. Which electrolyte imbalance should the nurse monitor for? A, hyperkalemia. B, hypokalemia. C, hypernatremia. Or D, hypercalcemia. So I see B, which is hypokalemia. Okay, what kind of drug is furosemide? Hypokalemia. Nice, okay. What kind of drug is furosemide? Yes, it's a loop diuretic. Okay, so potassium wasting. Good. All right, so you'll be definitely monitoring for your low potassium. So loop diuretics like furosemide increase potassium excretion, potentially leading to hypokalemia, which can cause arrhythmias and muscle weakness. All right. If you have a patient that has hypokalemia, we know that, we'll put them on the cardiac monitor and everything because of the arrhythmia. If you have a patient that has hypernatremia, what are some of the signs and symptoms you're thinking about for that patient? If somebody has too much sodium on board, what are some of the signs and symptoms you're thinking about for that patient? Seizures, definitely. Confusion, coma, things like those. Peak T waves, confusion. All right, so bradycardia. Okay, nice. Dry lips, yes. All right, and for a patient that has hypercalcemia, muscle twitches, oliguria. Okay. And then for the patient that has too much potassium on board, what are you looking for in terms of side effects or, their signs and symptoms? Such as arrhythmias. All right, okay, nice. Peak T waves, okay. Muscle twitches, yes. All right. Dehydration. All right, definitely. You guys are saying it all. Okay. So Carousel, I don't know if you're still here. I haven't seen you answer any question as yet, but big up yourself and you know why. All right. And big up to all of the folks here. Thank you so much for tuning in. Really appreciate you taking the time out. All right. And thank you for the gifts and for following the page. All right. And if you need the video, you can always go over to YT. The full live stream will be over there. So you can definitely go over and subscribe and watch the video at your own convenience later on. All right. Not a problem, Denique. All right. So a nurse is providing education for a patient starting warfarin. Which statement by the patient indicates understanding? A, I will use an electric razor and soft toothbrush to reduce bleeding risk. B, I can eat unlimited green leafy vegetables. C, I should stop taking warfarin if I feel fine. D, I will avoid all medications that interact with warfarin. A. Okay, nice. I will use an electric razor and soft toothbrush to reduce the bleeding risk. Definitely. All right. Patients on warfarin have an increased bleeding risk. Proper precautions include avoiding activities that may cause cuts or trauma, and monitoring dietary vitamin K, not eliminating it completely. So if you have a patient that, is overdosed on warfarin, what is going to be your medication to counter that? You don't want them to be bleeding out. Definitely Yara. K, okay, vitamin K. All right. So So if you have a patient that was on heparin, if you have a patient that was on heparin, if this patient was on heparin, what would have been the antidote for that patient if they were overdosed on the heparin? Yeah, protamine sulfate, definitely. All right, definitely. Yes, Susie, the protamine sulfate. All right, so definitely for this patient, you'll go ahead and, make sure that they're not doing anything that is going to promote or cause them to be having increased bleeding. All right, which assessment finding is most concerning for patient receiving IV heparin? A platelet count of 90,000, mild bruising at the IV site, slight headache, or a blood pressure of 130 over 80. So you have a patient that is on heparin IV. Which assessment finding is most concerning for that patient? A platelet count of 90,000, bleeding, a mild bruising at the IV site, slight headache, or a blood pressure of 130 over 80. I'm learning a lot of new things here because I work in psychiatry. Okay. Okay, nice. I'm happy to hear that, Frank. All right. So platelet count of 90,000 definitely is the answer. All right, because you know that heparin-induced thrombocytopenia, and that is a complication. So you definitely want to make sure you're observing or looking at that number. All right, heparin-induced thrombocytopenia. And the normal is 150 to 400,000. Definitely, Shayna. All right, and we already talked about the antidote for that, which should have been the protamine sulfate. Would you be concerned about bruising at the IV site? No. All right, slight headache. No. Blood pressure 130. No. Wouldn't be really concerned about all of those. Keep an eye on the blood pressure though, but we wouldn't really be concerned about anything else for this patient. A patient with advanced liver disease is at risk for which complication? A, hypoglycemia. B, hyperglycemia. C, hypertension. D, hyperkalemia. If they're hypotensive, definitely, Mandy. Expected side effects, yes. So a patient with advanced liver disease is at risk for which complication? A, hypoglycemia, B, hyperglycemia, C, hypertension, or D, hyperkalemia. Remember to go ahead and tap up the live. Thank you guys on YT for tuning in. All right, remember to hit the like button. All right, and we're just going through some questions. Okay. So, patient with advanced liver disease is at risk for, I know you guys probably would have said B. Why you said B? Why hyperglycemia? So, just think of, say you have a patient that has, all right, so Shayna says D. Watchman says D. All right, the answer is actually A, hypoglycemia. All right, it's actually hypoglycemia. Every time I have this question, we tend to just remember that the liver stores your glycogen, all right, and performs glucogenesis. So liver disease, impaired glucose production increases the risk for hypoglycemia. All right. So definitely, so if you have a patient that has liver problem, you want to keep a close eye on their their glucose levels. So you keep monitoring them because they're going to be at risk for hypoglycemia. Oh, let me pull this up, sorry. All right, so definitely keep an eye on them for, your the low glucose. All right, so go ahead and check because that's going to be something that is going to be dropping. All right. A patient with traumatic brain injury has a Glasgow Coma scale score of 6. What's the nurse's priority action? A, prepare for intubation and mechanical ventilation. B, position the patient in IFOLAs. C, administer analgesics for pain. Or D, encourage family visitation. So a Glasgow Coma score of 6, is that good or bad? What's the normal? Okay, so A, what is the normal score for your GCS? What are you looking for? 15. Okay, so definitely 13 to 15 is, the normal. Okay, yes, that's what you're aiming for. All right, so anywhere there. So 6 would have said that this patient is ready to be intubated. All right, so prepare the patient for intubation and mechanical ventilation. So Glasgow Coma score of 8 or less indicates severe brain injury and compromised airway protection. Airway management is priority to prevent hypoxia. All right. So you have a patient that has a traumatic brain injury as a GCS of 6. What's the nurse's priority action to go ahead and prepare the patient for mechanical ventilation? In the meantime, what are some things that you'll be monitoring for in terms of your assessment of your patient? Apart from your GCS, what other assessment you could be doing for this patient with a brain injury? Or what are some of the findings you're expecting for this patient with a traumatic brain injury? Watch for increased intracranial pressure. Okay, confusion. Okay, cerebral edema or stat. Okay. All right. What about their pupils? Loss of consciousness, pulse, ox. Okay, level. Okay. Pupillary changes, definitely. All right. All right, so you have a patient that has traumatic brain injury in terms of like, you know, and you'll be observing the patient for seizures as well, right? This patient is going to be at risk for seizures. So definitely you'll be observing and monitoring, all right, for that as well. Respiration, definitely. All right. So which patient requires the nurse to implement droplet precautions? A, the patient with posturing. Okay, nice, especially seeing that they're severe. All right. So which patient requires the nurse to implement droplet precautions? A, the patient with influenza. B, the patient with tuberculosis. C, varicella. Or D, the patient with MRSA. So you have a patient that needs droplet precautions. Which of these patients you're going to be placing? Let's see. A, the patient with influenza. Okay, A, influenza, definitely. All right. The patient with influenza. The patient with tuberculosis, what kind of precautions will you be doing? B is going to be airborne. C is tricky. What kind would you do for C? The patient with varicella. So the patient with varicella is going to be what? C is airborne and contact. But if they have open like blisters and all, will that change anything or will they still remain at, so airborne and contact? Yes. So if they have blisters or if they have, yes, if they're open, it's going to be airborne. All right. D is going to be contact. All right. Nice. All right. So influenza is transmitted via droplets. Tuberculosis requires airborne precautions. Varicella requires airborne, and MRSA requires contact precautions. All right. So for this, it says varicella airborne. All right. So you have a patient that is receiving TPN via central line. Which finding requires immediate intervention? So you have a patient that is getting TPN via the central line. Which finding requires immediate intervention? A, fever and chills. B, mild hyperglycemia. C, slight edema at the IV site. Or D, nausea. Susie says A. Oima, A. Nice. Mild fever and chills. Why are you concerned about fever and chills for this patient? Thank you for tuning in. Remember to go ahead and tap up the live, and you can also share. All right. The more you tap, the more persons come over. Definitely, you'll be concerned about infection because you know the patient has a central line. So, systemic infection. So you want to go ahead and total parenteral nutrition, Frank. All right. So you definitely want to go ahead and address that. So fever and chills may indicate that the catheter is infected. All right, indicate catheter-related bloodstream infection, a serious complication requiring immediate action. So you have this patient, and the patient is suspected of having infection on board. How are you gonna go about with starting, you know, your management? Talk about some of the things that you'll do for this patient. So you have the patient that has a central line. The patient develops fever and chills. What are you gonna be doing? Hi, Angela. Discontinue the infusion first. Okay. So infusion is off. Assessment. What are you? Assessment, definitely. What other things can you do in the meantime? Are you planning on getting blood cultures, things like that? Collect blood sample for identifying, stop, assess labs, cultures, definitely. Are you going to be getting 1 or 2 cultures from the same site, or how are you going to go about getting your blood culture? So the patient already has the IV in place, so where are you going to get the blood culture? So you're going to get 2 blood cultures from 2 different sites. All right, broad spectrum until culture results come in. Can we get the blood culture from the central line? You can always get a sample from the central line. Just label it that you get it from there. All right. Sometimes you can also send the tip of the catheter from the central line to the lab, just to make sure that, you know, at least they get to see whether or not the infection is definitely at that site. So nothing is wrong with getting a sample from the from that line, the central line, and send it off. You can also get 2 cultures from 2 different sites. All right, because it will tell whether or not it's definitely the catheter that is, you know, causing that infection. You get it from 2 different sites and you send it off. Just make sure you label it, like left arm, right arm, things like that. All right. You get your blood cultures, you get your lactic acid, and then from there you start your antibiotic afterwards. All right. So if you're supposed to get the blood culture and you realize that this patient is a very hard stick and you can't get the amount of blood that you need for your blood cultures, what will you do? You have the order for your antibiotics. Would you give it, or would you wait, or what would you do for that patient? Not a problem, Denique. I'm happy you are. So if you guys are struggling with getting the blood culture for this patient and you realize that this patient has a fever, chills, there's infection, you know, 4 persons come in and poke the patient, can't get it, you just go ahead and start your antibiotic, all right? Because that is very important right now. All right, so if you can't get the blood culture, don't delay the antibiotics. You know, just document whenever you get the blood cultures, then you can always document that, oh, you already gave vancomycin. So at least they'll have an idea of what is on board in that blood sample. All right. And then from there, start and document, definitely. All right. A patient with Parkinson's disease is experiencing increased tremors. Which medication is likely prescribed? So you have a patient that has Parkinson's and is experiencing tremors. Which medication is likely prescribed? A, levodopa. B, metoprolol. C, diazepam, or D, donazepam, Zil. The levodopa, carbidopa, definitely. All right, so that one increases your dopamine levels in the brain, improving motor symptoms in Parkinson's disease. Metoprolol is what kind of medication? They love levodopa. Okay, nice. Metoprolol is what kind of medication? Beta blocker. All right, nice. And what are some of the effects of beta blocker? So let's say it causes your heart rate to, you know, be lowered. It decreases your heart rate. What are some other things you're expecting with your beta blockers? Calm you down. Makes you mask hypoglycemic. Yes, so definitely for your diabetic patients, you have to be careful with that. Hypertension, bradycardia, your asthma patients, you also have to be careful with that medication as well. Diazepam, what kind of medication is your diazepam? Zorian?
Where's Daddy?
Working. It's a benzo, definitely. All right, anti-anxiety, seizure. Okay, definitely. How will you correct reverse a patient that has been overdosed on benzos? So you have a patient that comes in overdose, they took Xanax, they took some diazepam. Okay, flumazenil. Okay, flumazenil, fluoxetine. So the correct one is the flumazenil. All right, yes, nice. All right, and the donepezil, that one is for what? What class of medication is that one? And that one is also called Aricept, all right? And it's a medication that they use to treat like dementia, antipsychotic. So they use it for like dementia and Alzheimer's, all right? So, SSRI, okay. All right, so levodopa, carbidopa increases dopamine levels in the brain, improving motor symptoms in Parkinson's disease. All right. A patient is scheduled for colonoscopy. Which preparation should the nurse provide? A, administer bowel cleansing. A bowel cleansing agent as prescribed. B, encourage high residue diet 24 hours before. C, administer IV antibiotics. Or I realize. Or D, keep the patient NPO for 48 hours. So we're not going to linger on it because we already see the answer. So definitely you want to clean out that bowel. All right. You want to go ahead and clean out that bowel before they get that colonoscopy done. All right. Encourage high residue diet 24 hours before. No. All right. Administer IV antibiotics not needed. Keep the patient NPO for 48 hours. You don't need to keep them NPO for 48 hours. All right. Just need to clean out so they can actually get a clear view when they're doing the colonoscopy. All right, let's go. Which patient requires immediate attention? You have a post-op patient with a blood pressure of 90/60 and a heart rate of 120 beats per minute. A patient with a blood pressure of 140/80 and heart rate of 80. The patient with mild headache or the patient scheduled for discharge. So which one requires immediate? Okay, nice. The post-op patient with a 90/60 and a heart rate of 120. What are you thinking for this patient? What are you thinking is going on? Hemorrhage, possible bleeding. Looks like shock. All right, nice. All right. So the post-op patient, 90/60 with a heart rate of 120. So the patient is hypotensive, tachycardic. All right, so post-op may indicate hemorrhage or hypovolemic shock and requires urgent assessment and intervention. So you're there with this patient and you realize this. What are some things you can do in the meantime for this patient? Hi, Unbroken. Hi. What can you do if you're suspecting shock for this patient that just came from, the OR or, post-op patient? What can you do in the meantime for that tachycardia? Apart from putting the patient on the the cardiac monitor, definitely you want to go ahead and start some IV fluids. Assess the source of bleeding, administer IV fluids, definitely. Vital signs, good. All right, and you can also reposition. If the blood pressure is trending down, you can always reposition the patient as well to help with that. All right. Patient scheduled for discharge is going to be the last one to, go. Patient with mild headache, not so concerning. 140/80, can work with it. Blood pressure is a little bit elevated, but we can work with that for now. All right. So definitely your tachycardia is the problem there with that blood pressure. A patient with chronic venous insufficiency reports leg pain that worsens when standing. Which intervention is most appropriate? A, let me push this up a little bit. A, elevate legs above the heart level. B, apply cold packs. C, encourage prolonged standing. Or D, apply elastic bandages tightly. All right. So definitely you want to go with A. Everyone is saying elevate the legs above the level of the heart. And why do we elevate the legs above the level of the heart? Due to the peripheral. Okay. Why do we elevate above the level of the heart? Venous return. All right. So this patient has venous insufficiency. So you definitely want to make sure that that pooling, the swelling down there, all of that fluid goes back to the heart there. All right. So it relieves the discomfort in chronic venous insufficiency. And from there, applying cold packs. Would you apply cold packs to this patient? Will this patient benefit from cold packs being applied to the legs? No, definitely. What will happen if you decide to go ahead? It's gonna cause constriction. All right, so you don't want to apply that to the patient. All right, it's gonna cause vasoconstriction and then cause further problems there. All right, encourage prolonged standing. No. Apply elastic bandages tightly. No. You can always do your compression stocking, but not too tightly. All right, so you can always do your compression stocking, but tightly there, no. Elastic bandages, no. All right. Which finding indicates a patient is experiencing septic shock? A, warm flushed skin with hypotension. B, cold clammy skin with bradycardia. C, cyanosis with hypertension. D, jaundice with hypothermia. So which finding indicates a patient is having septic shock? Warm flushed skin with hypotension. B, cold clammy skin with bradycardia. C, cyanosis and hypertension. Or D, jaundice and with hypothermia. B. Ariel B. Okay. So the patient is having septic shock. So warm flushed skin with hypotension. All right. And we know that in early sepsis, you tend to have a lot of vasodilation going on. All right. So you're going to have the skin being warm. They're going to be hypotensive. All right. They're going to be warm, hypotensive. So you want to make sure that you prevent organ failure. So tachycardia instead, definitely. All right. So they will be tachycardic. All right. So cold, clammy skin, bradycardia is out of it. Cyanosis with hypertension. Jaundice with hypothermia, no. All right. A nurse is teaching a patient with asthma, proper inhaler. Oh no, I read this yesterday in my brain. A nurse is teaching a patient with asthma, proper inhaler technique. Which statement indicates correct understanding? A, I will hold my breath for 10 seconds after inhaling. B, I should exhale into the inhaler before inhaling. C, I will take quick shallow breaths during inhalation. Or D, I can skip the spacer if I want faster relief. Man, this is A, definitely. You hold your breath for 10 seconds before, after inhaling. All right. So holding your breath ensures medication reaches deep into the lungs for maximum effect. Shallow breaths and skipping the spacer reduce drug delivery. All right, full dose. Okay, all of it. All right. How do you tell when a patient is doing, an asthma patient is doing? What test can you do, use to check how well they're doing in terms of their asthma? What do we normally do for asthma patients? Pulmonary function. The peak flow, definitely. So you always do the peak flow to see how they're doing with their asthma. All right. The flow meter, yes, the spirometer. Okay, nice. All right. All right, so you have a patient that is asthmatic. What are some class of medications you're anticipating for this patient? So you have a patient that is asthma patient. What inhaler, what class of medications you're thinking they're getting? Your bronchodilator, your SABA, definitely. What is an example of your bronchodilator that these patients will be having? Your albuterol, salbuterol, definitely. All right. What about your SABA? Anticholinergic is another one, definitely. What about your SABA medications? What medications you're anticipating for that? Well, it's the same. You're okay. All right. So you're saying levoalbuterol. You know, those are okay. Your long-acting salmeterol, Ventolin, definitely. All right, and your anticholinergic. This thing is moving so fast. Okay. I need to figure out how do I do that. Okay, so I see that. And your Atrovent. One of your anticholinergic would have been like your Atrovent. All right. Your Atrovent, your Spirivir, all of those medication. All right. To help with drying up some of that secretion. All right. Okay, long-acting Ventolin. Okay, nice. All right, so we're gonna go ahead and do some more here. So a patient with chronic heart failure is prescribed digoxin. Which symptom indicates digoxin toxicity? A, bradycardia and visual disturbances. B, increased appetite. C, hypertension. Or D, insomnia. So if a patient that has chronic heart failure is prescribed digoxin, which symptom indicates digoxin toxicity? Definitely your bradycardia with your visual disturbance. All right. So you have nausea, vomiting, visual changes, and yellow-green halos as well. All right. In terms of your visual changes, monitoring your heart rate before each dose is essential. All right. So if you have a patient that has a heart rate of 40, will you be giving this patient that digoxin? No, definitely. All right. So you want to make sure what rate are you looking for before you give your digoxin. You hold it. Yes, you definitely anything above 60 should be good for your digoxin. All right. All right. What are some other medications that they use to treat heart failure? What are some other medications you can think of that they use to treat heart failure? Your Lasix, any form of diuretic, yeah, your beta blockers, okay. Antidiuretic, yes. All right. Cardivolol, ACE inhibitors, furosemide, yes. All right. All of those are pretty good. ACE, ARBs, calcium channel blocker. All right. All right. A patient with a history of seizures is prescribed phenytoin. What's the other name for phenytoin? What's the other name for phenytoin? Dilantin, definitely. So you have a patient with a history of seizure being prescribed phenytoin. Which lab should the nurse monitor? A, serum drug levels. B, blood glucose. C, liver enzymes only. D, platelets only. So you have a patient that has seizures and the patient is on phenytoin. What are you monitoring for? A, serum drug levels. B, blood glucose. C, liver enzymes only. Or D, platelets. AA, which is serum drug levels, definitely. All right, because of the therapeutic range, you want to make sure you're monitoring that. All right, to ensure that the medication is effective and at the same time prevent toxicity. All right. Yeah, we'll keep an eye on the glucose as usual for your NCLEX. If you see any question that says or the answer says only, always use the process of elimination and just mark those off. All right. So the liver enzymes only is gonna be out. The platelets definitely gonna be out. All right. So back to your seizure. What are some other medications you can use for seizure control? Oh, do you monitor with the blood? You do your blood, your serial blood, Lily. Your blood test. All right. So they'll do a lab draw to see what the levels are looking like. And then from there. All right. What are some other medications you can use to treat your seizure patients? Anticonvulsants, Tegretol, carbamazepine, diazepam, definitely. You have your Keppra. All right. If you have a patient, GABA, okay. Depocate. I remember Depocate. I don't know if Depocate was okay, vaporic acid, migraine, bipolar. Okay. Okay. All right, nice. All right, and what are some things? Ascorbic acid. Okay, all right, nice. What are some things you can do in the meantime in terms of interventions? So you have a patient that is on seizure. What can you do in terms of for, making sure that this patient is safe? What are some things you can do in the meantime, for your patient? So we already have their seizure medications on board, turning on the side if they're having active seizure, lowering the bed, nice. All right. Turn the head side to prevent aspiration, pull the bed rails up, definitely. Make sure you have your bed in, the lowest position and always have your bed rails up, or you can put on your seizure pads. All right, nice, okay. So what if this patient is pregnant? If you have a patient and the patient is pregnant, the patient is having seizures. All right, so you're gonna do all of those. What medication are you thinking about for that pregnant lady? So you have a set of medications in the department. What medications would you be thinking about for that patient, that pregnant patient? Your magnesium sulfate, all right? So if the patient is pregnant, run for your magnesium sulfate. And why you're, nice, Toya. All right. So if this patient is pregnant, having seizure, what condition are you thinking about? What are you treating with your magnesium sulfate? What are you treating with magnesium sulfate? So eclampsia. So we're treating eclampsia, Lily, nice. All right. Okay. Yeah. All right. Okay, eclampsia. Remember to go ahead and tap up the live, share the live. All right. I'm enjoying this. All right. So a patient receiving chemotherapy, oh my word, pretend as if you never see it. A patient receiving chemotherapy develops mucositis. What is mucositis? So a patient having mucositis, what is going on? Yes, inflammation of where? The mouth. Okay, nice. All right, so they're having mouth sores because of that. All right, so inflammation of the mouth, mucous membranes. Okay, so the patient is receiving chemotherapy, develops mucositis. Which intervention is best for this patient? A, provide soft, bland foods. B, encourage acidic foods. C, brush teeth vigorously. D, give alcohol-based mouthwash. Oh, so A provides soft, bland foods, definitely, because this patient's mouth is inflamed. All right, so you don't want to give anything that is gonna, you love the answers. I tell you, encourage acidic foods, brush teeth vigorously, give alcohol-based mouthwash. Those are definitely out, all right? Even when you don't have mucositis, you're not using those, so, or you're not doing that. So definitely it's mucositis causes oral pain and risk for injury. Soft, bland foods reduce irritation. Acidic, spicy, or alcohol-based products worsen the symptoms. All right, so definitely you'll provide soft, bland foods for this patient. All right, let me scroll down slowly. Nice. A patient with anemia has hemoglobin of 7. Which symptom is most concerning? A, dyspnea at rest. B, mild fatigue, pale nail beds, or D, lightheadedness on standing. So I have a patient that has asthma, that has anemia, the hemoglobin is 7. Which symptom is most concerning? The dyspnea at rest, mild fatigue, pale nail beds, or C, lightheadedness on standing. A, dyspnea at rest. All right, nice. All right, the others are going to be pretty, common with a patient, but you want to make sure that dyspnea at rest is addressed, because that means the patient has severe anemia and there is inadequate blood flow, because we know the hemoglobin carries, the oxygen. All right. So you definitely want to address that. What is the normal hemoglobin level for a female? What's the normal hemoglobin for a female? 13 to 16, 12 to 20. That's a little bit. 120 to 60, 12. I've seen a ton. 14 to 18 males, 13 to 16 for females, 12 to 16. Okay. All right. So anywhere between that range there is pretty good. All right. So if you have a patient with that, how will you tell the hematocrit for this patient? How can you calculate the hematocrit for this patient? Using just the hemoglobin. How will you know the hematocrit for this patient? Just by looking at the hemoglobin. All right, so the hematocrit is going to be 3 times your hemoglobin level. All right. So whatever the hemoglobin is, your hematocrit is going to be 3 times that. All right. So that's the quickest way to remember it. All right. I remember both of them goes hand in hand. All right. All right. Mild fatigue, as I say, is going to be expected. Pale nail beds, lightheadedness on standing, they probably have that because their hemoglobin is low. So 26 to 36 is going to be the, okay, 3 times 7 to 21. Okay, nice, Ohima. All right, so whatever it is, it's going to be 3 times. So if the question says, okay, go ahead and tell the hematocrit for a patient that has a hemoglobin of 7. You multiply the 7, which is going to be 21%. All right. All right. So you have this patient that is having severe anemia. Tell me about some of the things you can do for this patient in the meantime, or what are you anticipating for this patient in terms of the plan of care? Blood transfusion, oxygen, nice. Okay, all right. So you're definitely going to be prepping this patient for blood transfusion, IV fluids. But the patient definitely needs the blood. All right, patient definitely needs the blood because that is what they're low on. Oxygen, definitely. So you'll get the patient onto that. You'll get their consent. All right. So for example, now you get the blood. And oh, remember your 2 large bore IVs. All right. Your 2 large bore IVs. You have your blood. So how do you go about with monitoring? Blood group typing, definitely. All right, you need that as well. So you get the blood that you're administering. How long are you going to be hanging out with this patient? How long are you going to be monitoring this patient for? Folic acid. Okay, so the first 15 minutes you'll be there with the patient. First 30 minutes you'll be there. Okay, all right. So 15 minutes, the first 15 minutes you stay with the patient to make sure the patient is not having a reaction. If you notice that the patient starts developing a reaction, what do you do? So you're giving this patient blood, the patient starts complaining of worsening shortness of breath, patient starts having rashes. What are you going to be doing? You stop stop the blood. Okay, all right. Walk me through it. You stop the blood and then what? Give saline, okay. Remove the bloodline, definitely, because if you go ahead and introduce your flush, you're flushing that blood, what you're doing is causing more reaction, because remember the tubing has the, you know, the blood in it that the patient is having the reaction to. All right, so you take out that line, and that's why you have your second line. You go ahead and use up your second line. All right. And then what do you do? Do you throw the blood in the bin? Send the blood and tubing back to the lab. Nice, Chinoni. Chinonai. Send the blood back to the lab. All right. And then you'll anticipate probably giving some medications. There's some antihistamines. Depending on what is going on, you go ahead and you start your treatment based on order. Yes. All right. And you keep on monitoring. Epinephrine. It depends on what's going on, you know, they can give the epinephrine. It depends on the severity of what's going on. All right. Yeah. So you definitely want to do all of that and monitor the patient, document, and then from there. All right. A patient with acute appendicitis is NPO. A patient with acute pancreatitis is NPO. What is the primary reason for the intervention? A, reduce pancreatic stimulation. B, prevent dehydration. C, avoid constipation. Or D, maintain glucose level. So, a patient with acute pancreatitis, the patient is NPO. What is the primary reason for the intervention? A, reduce pancreatic stimulation. B, prevent dehydration. C, avoid constipation. D, maintain glucose levels. So A, C, A, reduce pancreatic stimulation. Someone says to avoid constipation. So Butter, welcome. All right, so you want to reduce pancreatic stimulation there. With this patient with acute pancreatitis, yes, Butter. With this patient with acute pancreatitis, are you thinking the patient is going to be hyperglycemic or hypoglycemic? What are you monitoring for? Hypoglycemic. Okay, definitely. Let's get this back up. Hold on 1 minute. So definitely the patient is going to be hypoglycemic. All right. So you want to definitely reduce any form of pancreatic stimulation. All right. So fasting prevents the pancreas from secreting digestive enzymes, which reduces inflammation and allows healing. Don't go. This is interesting. Yeah, I don't know what's happening. All right. So definitely you want to keep this patient NPO to reduce, you know, any form of stimulation there. All right. For your pancreas, what are some of the labs you'll be monitoring for this patient? So what labs will you be monitoring for? And whether or not they're going to be high or low. Okay, so yeah, your A1C eventually, not that, you know. What is the A1C? Let's go. What is the A1C? So we're definitely going to be looking at the glucose, all right? But your A1C is what? Is it going to really give you anything, you know, that is going to be needed right now? So you want to look at your amylase, your pancreatic enzymes, all right? So you want to keep an eye on those. Will your pancreatic enzymes be elevated? So your amylase, your lipase, all right, nice, all right, protease, all of those things. Are they going to be elevated or, you know, yes, they're going to be definitely elevated. So you want to keep an eye on them. Let's get back to the A1C there. What is the A1C? What is A1C? A1C is test to know the level of glucose within 3 months for diabetic patients. Yes. So how the patient is actually doing with their medications. All right, nice. In the last 3 months. All right. So in the hospital, like if you have this patient now, will this be, you know, important priority for this patient right now? No. All right. So this one will be priority. I see someone else says PTT. All right. So for your pancreas and your PTT, why are you concerned about the PTT for this patient? I think it was Shayna. Shayna, what are you thinking about? Will you have an elevation in your PTT? What's going to be happening? Yeah, you're going to have like elevations in your PTT level, all right? Usually when you have the prognosis for these patients being so poor, a lot of times you might have the elevation, all right? The elevation in the PTT, all right? Yes, a coagulation problem, nice. All right. So which electrolyte imbalance is most concerning in a patient with prolonged PTT? I think is for warfarin. Yes, it is for warfarin. It is for warfarin. But you will have patients with pancreatitis. All right. Sometimes you have the patient with pancreatitis. Their PTT levels tend to be elevated as well. All right. So which electrolyte imbalance is most concerning in a patient with prolonged vomiting? A, hypokalemia, B, hyperkalemia, C, hypernatremia, D, hypocalcemia. Okay, hypokalemia. Okay, nice. Losing acid and potassium, this definitely. Okay, so if you have this patient that is having prolonged vomiting, what acid-base imbalance are they experiencing? Metabolic alkalosis. Yes, metabolic alkalosis. All right. All right. So this patient is in hypokalemia because of the excessive or prolonged vomiting because they lose their gastric juice. All right. And their potassium, increasing the risk of arrhythmias and muscle weakness. All right. If you have a patient that has hyperkalemia, yes, it's they're losing acid. Nice. If you have a patient that is hyperkalemic, what is going to be happening in terms of their EKG? What are you going to be seeing on their EKG? You're going to have the prolonged, the peak T waves, definitely. You'll be looking for your peak T waves, all right? If the patient is hypokalemic, what are you expecting on their EKG? Inverted, flat, spikes, flat or narrow T waves, all right. All right. So just the opposite of the hyperkalemia, all right. Hyper prominent and the prominent U wave, all right. And the QT interval can sometimes be prolonged as well, all right. Nice. All right. How would you treat a patient with hypernatremia? A patient that has hypernatremia, how would you treat that patient? Hyper widen QRS. Okay, nice. How would you treat a patient that has too much sodium on board? Hypotonic fluids. Okay, nice. All right. Dilute. Okay, nice. So so for the hypotonics, potassium or sodium? Sodium. So you want to make sure you're monitoring their vitals, look at their hydration. All right, you can always start with your 0.45% sodium chloride. Sometimes they'll do the 5% dextrose. All right, so it depends on what is happening in terms of hydration for that patient. All right. 3% normal saline, definitely. All right. A patient has tension pneumothorax. Which finding is most concerning? A, tracheal deviation to the opposite side. B, mild dyspnea. C, crackles on auscultation. Or D, productive cough. So you have a patient that has tension pneumothorax. This is somebody that you'll just send them home and say, hey, come back next week and we'll do another chest x-ray. So A, tracheal deviation to the opposite side. Okay, is this an emergency or not? Yes, definitely it is. It is a emergency. So the tracheal deviation on the opposite side. All right, that is the one that is most concerning. Patient will have the shortness of breath, crackles on auscultation. Who are you expecting to have crackles on auscultation? Which patient? Emergency impedes breathing, definitely. Your heart failure, emphysema, fluid overload, pulmonary edema, definitely. Productive cough, you'll think about your CHFs as well. All right. So what is the, how do you go about with managing your tension pneumothorax? So you have a patient that has tension pneumothorax. How are they going to be treating that patient? What are you expecting for this patient? A chest tube, nice. All right, so if you don't have a chest tube readily available, what else can they do to help with that pneumothorax? The needle decompression, nice. Which side will they be decompressing? Where would they be putting the needle, Sash? On the left side, the right side, the side that is affected? Which side are they going to be putting it on? The affected side, nice. All right. Just think of a balloon, it's, inflated. You just go ahead and puncture, reduce it, yes, get rid of that air. All right. So tracheal deviation on the opposite side. So tracheal deviation indicates severe pressure buildup in the pleural space, a life-threatening emergency requiring immediate decompression. All right. When you have, so to bring back the tracheal to midline, definitely. All right. What if you have, so we know that pneumothorax is the air in the lungs, in the chest cavity there, all right? What is the hemothorax? What is hemothorax? Blood, nice, all right. And pneumothorax? Pneumothorax, blood and air, definitely, nice. All right. Yes. So a nurse is assessing a patient with cirrhosis. Which organ are we thinking being affected here? You have a patient with cirrhosis. Which organ is affected? The heart, the eyes, the lungs, liver, nice. Which finding requires immediate intervention? A, ascites and confusion. B, mild fatigue. C, slight jaundice. Or D, loss of appetite. So you have a patient with cirrhosis. Which finding requires immediate intervention? A, ascites and confusion. B, mild fatigue. C, slight jaundice. Or D, loss of appetite. A, which is the ascites and confusion, definitely. Why are you concerned, with that one? What are you thinking? So you have a patient that has cirrhosis. All right. The confusion means that there is ammonia. It's increasing. All right. Definitely. This is someone says they talk about the encephalopathy, ammonia levels increasing, and it needs to be reduced. So you give your lactulose, definitely. peritonitis, hepatic encephalopathy. Okay, nice. What if they never had the confusion there? What if there wasn't any confusion and the patient was just having ascites? Would you be like, would you be still concerned about, that patient? If there was no confusion, what if the patient was just, having ascites, mild fatigue, slight jaundice, loss of appetite? Would would that patient require immediate intervention? Ascites, electrolytes imbalance, definitely. So they will definitely need that paracentesis to help with reducing that. All right, nice. Okay. All right, but with A, the confusion is the problem there because of the ammonia. All right. So definitely you want to go ahead and address that. The confusion indicates hepatic encephalopathy, which is a serious complication of liver failure. Immediate medical management is needed. All right. What are you expected in terms of with this patient and their, let's see, who had said it again? Their PTT. Their PTT. Is it going to be abnormal, or what's going to be happening to these patients and their platelet and their PT? It's going to be deranged, definitely. All right. Well, all right. Why is it deranged? Can I ask a question? Definitely, Oyima. Sure. Thank you for the heart meal. Oh yes, go ahead and remember to do your heart meals, your daily heart meals. All right. Remember to do your daily heart meals, and then from there. All right. Where is she? So where is she? Oh, albumin. So what fluid do you give? What fluid do you give to a patient after paracentesis? So it depends. So you can give the albumin. You can give the albumin to these patients because sometimes when they have the ascites and you do the paracentesis, you tend to drop, their blood pressure, and then with the protein and everything, you have that fluid shift. It's always good to give something that will expand and help with their blood pressure. So the albumin is fine. So it depends on what is going on with the patient, because sometimes you can't always give your isotonic fluid if they're still maintaining good blood pressure. So it depends on what is going on in terms of their lab value. All right. So, okay, albumin builds up their oncotic. Yes. All right. So depending on what's going on, if they're on their perfusion. Yes. All right. So you can give your albumin, but as I say, it depends on what is going on, the amount of fluids they've pulled off. All right. For those patients. So, all right. So which action is priority for a patient with hypoglycemia? The glucose that is 45 milligrams, or less. So you have a patient that has hypoglycemia. What will you do for this patient as priority? A, administer 15 grams of fast-acting carbohydrate. B, check hemoglobin A1C. C, provide high-protein snack. Or D, encourage exercise. What will you be doing for this patient? So I see C. Depends if they can eat, definitely. All right, so this patient is hypoglycemic situation. Didn't say anything regarding that, but based on the answer there, all right, if they are awake, you can give them something quick, sugar, juice. See AAA, which is administered 15 grams of fast-acting carbohydrate, which is good. High-protein snack. I see somebody says C. All right, so the carbohydrates act faster, so you'll always go ahead and give that. All right. So A would be the best option. So immediate correction of your hypoglycemia prevents neuroglycopenia and seizures. Follow up including rechecking glucose in 15 minutes. All right. So always go with your carbohydrate. As we said earlier, A1 is better than the protein bar, definitely. Your A1C is gonna give you, you know, how well their diabetes is, basically, you know, how over the last 3 months. All right, so that is not important right now. High protein is not preferred right now. You need them to be getting sugar, carbohydrates. All right, encourage exercise. This patient is hypoglycemic, so we eat, we don't have any energy. So this patient not gonna have any energy to go and do any exercise. You're gonna probably have this patient pass out on you. All right, so do you have to wait for doctor's order to administer antibiotics or fluid? You don't need antibiotics for this patient. All right, for the hypoglycemia, you definitely need your glucagon. All right, you need your glucagon, you need your glucose. So definitely, usually most hospitals will have, like, standing orders. Oh, in general, so you have standing orders when it comes down to hypoglycemia in a lot of hospitals. So depending on what the numbers are, then those orders are there, and you will go ahead and you'll go according to the orders that is in place. All right, so the orders are going to be there as a standing order, especially when you're on the med surg floor, inpatient setting. Those are a part of your admission order to say if the glucose is this, then you go ahead and activate those orders, and then you start your treatment. All right, usually start your dextrose 5 water. Yeah, so depending on what they order, you just go ahead and start it. All right. And the same thing for your antibiotics. I don't really know much about the antibiotics for the inpatient setting. All right, but usually they'll have the broad spectrum antibiotic that the NCLEX is a perfect word. That's what they say. Okay, yes. For the antibiotics, I know that, usually they'll have their orders, and then you'll go with whatever they say. All right. But for the NCLEX world, do you have to wait for orders? Yes, you have to wait for orders for everything. All right. So that's it. Hi, stay blessed 25. Thank you so much for tuning in. Thank you guys for tuning in. Sorry. All right. All right. So let's go over to this one. A patient with asthma uses a rescue inhaler frequently. What does this indicate? A, poor asthma control. B, effective prevention. C, no need for maintenance therapy. Or D, symptom-free status. So I have a patient that has been using the rescue inhaler frequently. What does this indicate? A, poor asthma control. All right, yes. All right, because it's a rescue inhaler. It's not something that is a maintenance. So they're not supposed to be using it that frequently. So obviously their asthma is not controlled. All right, so poor asthma control. It indicates worsening symptoms and poor control, necessitating reassessment of therapy and possible step up in medication. All right. Effective prevention, that's incorrect. No need for maintenance therapy. They need it, more than need it. And symptom-free status, definitely not. All right. A patient has a central line and develops redness and drainage at the site, at the insertion site. What's the nurse's priority here? Notify the provider and prepare for a line culture. B, apply a warm compress. Reinforce dressing only. Or D, flush line with normal saline. So we have a patient with a central line that develops redness and drainage at the insertion site. What's the nurse priority? Notify provider and prepare for culture, line culture. All right. Apply warm compresses out of it. Yes, so stabilis, clap C, definitely. All right, and that is something that is big in terms of, hospitals. They want to make sure that their numbers are 0. All right, so signs of infection at the central line site can progress to sepsis. Prompt assessment and intervention are critical. All right, and when you talk about clap C, you're talking about your catheter, what's it called again? Your catheter associated, central line associated, hold on, let me pull it up. Central line associated bloodstream infection. Thank you, Michelle. All right, so you talk about your central line associated bloodstream infection. All right, thank you. All right, so you have to make sure you're monitoring your patient and observing, changing their dressing as per order. For the central line, how often do we change that? Is it 5 days, 7 days? Is it 5 to 7 days? Who was it again, Michelle? Dressing change every 7 days. Okay, nice. Yeah. So every 7 days I change the dressing. All right. Or as needed. Yeah. Because if it is soiled, you definitely want to go ahead and remove it. 5 to 7 and when soiled. Definitely. All right. And is this a sterile procedure or not? Yes, it is a sterile procedure. Nice. All right. All right. It's sterile, definitely. A patient with an ileostomy reports frequent watery output. Which intervention should the nurse implement first? A. Assess fluid and electrolyte status. B. Encourage high fiber foods. C. Apply skin barrier cream. Or D. Increase physical activity. So I have a patient with an ileostomy that reports frequent watery output. Which intervention should the nurse do first? Assess fluid and electrolyte imbalance. Definitely. Why are you assessing fluid and electrolyte imbalance? Or their status? What are you concerned about? Yes, stay blessed. Nice. High output, watery output. Yes, so they're having that. They're at risk for dehydration. All right. They're at risk for dehydration because they're losing a lot of fluid there. So high output ileostomies can cause dehydration and electrolyte imbalances, which must be assessed and corrected promptly. Encourage high fiber foods. Is that something that you want to encourage this patient to be having? They will be at risk for hypokalemia, definitely. All right, because they're losing everything. No, you don't want them to be on high fiber foods because that's going to worsen their diarrhea or the output. All right, it's going to cause that stool to be more watery. And then from there, all right. Imodium as needed, definitely. All right. A patient is prescribed metformin. What kind of drug is metformin? What kind of medication is it's a diabetic drug? Okay. What class is it? What class is it? Diabetes type 2. What class of drug is that that metformin? Biguanide. Okay. All right. So you have a patient that is prescribed. That's fine. You have a patient that is prescribed metformin, which teaching point is essential. A. Take with meals to reduce GI upset. B. Avoid checking blood glucose. Skip doses if feeling well. Take at bedtime on an empty stomach. So take with meals to reduce GI upset. All right, so it can cause nausea, diarrhea, and abdominal discomfort. Taking it with food reduces GI side effects. The only thing that was missing was like S on it. It's actually nausea and GI upset. Yeah. All right. So patient with metformin, avoid checking blood glucose. You don't avoid checking blood glucose. You still check their glucose. Throughout the day. Skip doses if feeling well. No. Take at bedtime on an empty stomach. Definitely not. All right. So it causes nausea, diarrhea, abdominal discomfort. Taking it with food reduces GI side effects. All right. A patient with myocardial infarction develops sudden hypotension and the jugular vein distension. What are you thinking in terms of complication? A, cardiac tamponade. B, heart failure. C, stroke or pulmonary embolism. So if a patient that has myocardial infarction develops sudden hypertension and jugular vein distension. What are you thinking? B, heart failure. Okay. Who says A? Anybody says A? I see somebody says fluid overload. Okay. All right. So look at the words. The words in the question. So you have a patient that has a myocardial infarction, develops sudden hypotension and jugular vein distension. So use the process of elimination and try to answer this one. All right, so which complication is most likely happening here? All right, so A, cardiac tamponade. All right. So you have sudden changes. So this patient was in front of you, suddenly develops jugular vein distension. All right, you're having cardiac tamponade going on, which is the hypotension, the jugular venous distension, the muffled heart sounds are the Beck's triad. And those are classic signs of cardiac tamponade, which is a life-threatening emergency. Fluid accumulates in the pericardial sac, yes. All right, heart failure will eventually develop over time, so it's not something that is going to happen overnight, all right? Your stroke, the symptoms are going to be different for your stroke. Pulmonary embolism, what are some of the signs and symptoms of it can cause is hypotension? Shortness of breath, okay. For your pulmonary embolism, what are some of your signs and symptoms for your pulmonary embolism? Tachycardia, shortness of breath, your hypoxia, your chest pain, nice. All right, pain on inspiration. All right, so the one that would be most suitable is going to be your A for your cardiac tamponade there, which is a life-threatening emergency. All right. And usually when so low oxygen, confusion. Okay. All right, nice. Which finding indicates diabetic nephropathy? A, microalbuminuria. B, polyuria. Does pulmonary embolism cause fluid overload? No. No, you don't have pulmonary embolism causing fluid overload or edema. All right. Favor says dyspnea. Okay, nice. Stash says it can eventually. I guess if it's like thank you, Anna. I guess if it is like, carpal, okay, carpulmonary. Hold on. Carpulmonary. Left-sided heart failure. Okay. All right. Okay. Right-sided. What's the answer? Let's look it up. All right. So for your pulmonary embolism, what's the relationship with it? And heart failure. Carpulmonary failure. Let's do that one. Pulmonary embolism causes heart failure by obstructing blood flow to the lungs, which forces the heart to right ventricular to work harder and increase it. So the pulmonary embolism causes heart failure by obstructing blood flow to the lungs, which forces the heart's right ventricle to work harder and increases pressure in the pulmonary arteries. This strain can lead to right ventricular dysfunction, a condition called acute carpulmonale. And if the obstruction is severe or chronic, the heart can eventually become weakened and fail. So definitely, that is pulmonary hypertension. All right. So it definitely can cause, is it? All right. Who was that again? Thank you for that. Who was saying it? Sash. Thank you, Sash. All right. So the obstruction and the increase in pressure, blood clot travels to the lungs and blocks the artery. This blockage increases the pressure in the pulmonary arteries, definitely. You have the strain on the right ventricle, all right, which is responsible for pumping blood into the lungs. When the pulmonary artery pressure is too high, the right ventricle has to pump much harder to push blood through the blocked vessels. All right, the right ventricle dysfunction happened because this increased workload strain in the right ventricle, which can lead to decrease in its function. All right, this is known as acute cor pulmonale, a type of right-sided heart failure. Weaning of the heart is happening over time because of the constant strain, all right, that is going on, leading to the heart failure. Potential for chronic heart failure. In some cases, small clots can lead to scarring and chronic pulmonary hypertension, which can result in long-term heart failure. Nice, nice, nice. All right. Wasn't thinking that far down the line. So, yes, it does. All right. So, it does cause right ventricular dysfunction, which lead to your right-sided heart failure. All right. So, which finding indicates worsening diabetic nephropathy? So we say A. Okay, nice. Your microalbuminuria. All right. So that is an early marker of kidney damage in diabetes, indicating progression of nephropathy. All right. And we know that the patient will tend to have your polyuria. Will they have weight gain? Will they have weight gain in your diabetic patients, or it depends on, what's going on? Will you see like weight gain or weight loss? And if so, which one? Which one, Oima? Are you talking about which one you never heard about? Depends on how bad, definitely. All right, depends on how bad. It depends on if the patient have kidney failure. All right. Gain if they have retaining fluid, definitely. All right. If the diabetes affects the kidney, then the gain weight due to the edema. All right, nice. All right, and then we have the mild edema there. All right. Worsening diabetic. Okay. Microalbuminuria, worsening diabetic nephropathy. Okay. A patient is suspected with a patient with suspected meningitis as a positive Kernig sign. Which action should the nurse take? A, place patient on droplet precautions. B, provide oral analgesics. C, encourage ambulation. Or D, administer antipyretics only. So you have a patient that is suspected to have meningitis and the patient has a positive Kernig sign. Which action should the nurse take? A, place the patient on droplet precautions. B, provide oral analgesics. C, encourage ambulation. Or D, administer antipyretics. So wear a mask, definitely. All right. So always remember your precautions for this patient. All right. So place the patient on droplet precautions. Well, Kichi says A. Okay, nice. Favor says A. Good. All right. So place the patient on droplet precautions because it is highly contagious. All right. So immediate precautions prevent the spread while awaiting diagnostic testing and the treatment. Provide oral analgesic. Would you give this patient oral analgesic or would you keep this patient NPO? So this is a patient with suspected meningitis. Would you feed this patient? NPO, okay. Encourage ambulation. Will this patient be up for walking? You definitely want to go ahead and do your antipyretics, definitely. What test are you anticipating for your patient with meningitis? What test are you? And hi, Jacinth, the spinal tap. Yes, your lumbar puncture. All right, definitely. Are we giving antipyretic with meningitis? You can always do like a tepid sponge bath. You can always do all of those. They'll probably give some IV medication depending on, you know, the fever, how bad their fever is. All right, but most of the time, you know, they'll start them on their antibiotic. All right, they will start them on their antibiotic, but usually you want to try to make sure you get that spinal tap, and then from there. All right. We can always give, you know, you can do different forms of antipyretic treatment for these patients. So even if you're not doing, we can actually give, but droplet precautions come first. Yes, droplet precaution is the priority here. So you definitely want to go ahead and put on your precautions. All right. So you're protecting the other persons in the area. All right. Well, we're just kind of going through the answers to see why the answers are not correct, and just to kind of get a little bit more information on that. Even suspected cases, we need to put on precautions first. Yes. So if a patient comes into in your room and the patient is having shortness of breath, always think about, you know, the worst thing that is possible with shortness of breath. So go ahead and put on your precautions until, you know, you get back your results. All right. So bacterial meningitis, as I say, you go ahead and you do your precautions. So once the patient comes in and they are having the signs or symptoms of, you go ahead and put on your appropriate PPE until you get your testing done and the results, but you'll continue your treatment from there. All right. Hi, Jacinth. How are you doing? All right. A patient with COPD has a PaCO2 of 60 and a SpO2 of 88. Which intervention is priority for this patient? A, administer supplemental oxygen cautiously. B, encourage deep breathing exercise only. C, restrict activity. D, administer bronchodilator only. So you have a patient with COPD that has a CO2 of 60 and a SpO2 of 88. Which intervention is priority for this patient? All right. A, administer supplemental oxygen cautiously. B, encourage deep breathing exercises only. C, restrict activity. Or D, administer bronchodilator only. So we have A, and then Michelle says B, encourage deep breathing exercises only. Why do you say B, Michelle and Anna? So you have this patient with a PaCO2 of 60 and the SpO2 of 88. Why do you say B, to do deep breathing exercises only? Okay. So Ivana Ben says, okay. Ivana Ben says not. Those are not the answer because of the only. All right. Okay. So any answer that you see that says only is usually out of the equation. All right. Respiratory rate is low. And 88 is normal for COPD. Okay. So the answer is actually what? A. All right. So you want to give supplemental oxygen cautiously because with your COPDs, they have B CO2s because of their tidal volume. That's why it should be given cautiously. Definitely. All right. Definitely. All right. So remember that these patients, so the patient with CO2 retention are at risk for hypoventilation with high flow oxygen. So oxygen should be titrated to maintain a SAT of 88 to 92%. All right. So you give a small amount of oxygen and try to get their oxygen up to that 88 to 92. Encourage deep breathing exercise only. As I say, you encourage a deep breathing, but that only there. So B and C with the only, you'll definitely eliminate those. All right. Restrict activities definitely out of it as it's a part of it as well. All right, because this patient is already, you know, the oxygen is low, so you definitely want to make sure they're not using up too much. All right, and then from there, which symptom is most concerning for patient taking lithium? A, confusion and tremors. B, mild thirst. C, slight weight gain. D, fine hand tremor. So which symptom is most concerning for a patient taking lithium? Confusion and tremors. B, mild thirst. C, slight weight gain. Or D, fine hand tremor. Nice. What are you thinking about with the confusion and tremors? What are you thinking about for this patient with who is taking lithium and is confused? Your lithium, yes, your lithium toxicity. All right. So definitely it's due to low sodium. Nice. All right. So you always want to go ahead and monitor your patients. So these are signs of lithium toxicity. Immediate interventions includes holding the dose, checking serum levels, and notifying the provider. All right. Notifying the provider. And for your NCLEX, please remember, like if you have certain medications, know what medications require you to be monitoring vital signs as well as lab values. All right. Because those are going to be on the exam. Because at the end of the day, you have to remember that NCLEX is just making sure that you're thinking critically as well as you're giving safe care to the patient. All right. So know your lab values that go with what medication as well as what vital signs abnormalities or vital signs you'll be looking out for. All right. So a patient with a recent stroke has left-sided weakness and difficulty swallowing. Which nursing intervention is priority? So you have a patient with a recent stroke that has left-sided weakness and difficulty swallowing. Which nursing intervention is priority? A, assist with safe feeding and monitor for aspiration. B, encourage verbal communication. C, perform assistive range of motion exercises. D, provide emotional support. So a patient with a recent stroke and has left-sided weakness and difficulty swallowing, which is the priority nursing intervention. Which is good. Assist with safe feeding and monitoring for aspiration. Definitely. For this patient with the stroke, what tests can you do before, feeding this patient? What are you going to be doing? What tests can you do before feeding this patient? Because of airway. Okay. Speech evaluation. Okay. A swallow test. All right. Can do a swallow test for this patient as well. Speech evaluation. Sips of water. Okay. MBS. Gag reflex return. What's MBS? Just slopes? Okay. All right. So definitely you want to do a swallow eval, and then from there, you administer your food. All right. You give your patient your feed where they see where it goes. Where they see where it goes. Huh? Where they see where it goes. I'm not understanding, Michelle. MBS is like an X-ray. Okay. 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 All right. So definitely you want to monitor the patient for aspiration. All right. Will you give this patient to that is a gag reflex, I think. Will you give this patient to your UAP, your LPN, or will you, the RN, keep this patient? If you were supposed to delegate this patient, who will you delegate the patient to? Will this patient go to a RN, LPN, or the UAP? You'll keep no UAP, RN, definitely. All right. Okay, nice. And all the other things you can do for, you know, for the patient, but you'll keep this patient as a RN. All right. So dysphagia increases the risk of aspiration pneumonia, which can be life-threatening. Safety during meals is immediate priority for this patient. All right. All right. A patient is receiving vancomycin, which interventions prevents infusion-related reactions. A, administer over at least 60 minutes. B, administer rapidly to ensure efficacy. C, give with oral IV antibiotics simultaneously. Or D, stop monitoring vital signs during infusion. All right, so a patient receiving IV vancomycin, which intervention prevents infusion-related reactions? All right, so I see AAA, administer over at least 60 minutes. Okay, nice. What kind of medication is vancomycin? Uh-oh. What kind of medication is vancomycin? It's an antibiotic, definitely. All right, it's an antibiotic. Yes. So rapid infusion of vancomycin can cause your red man syndrome, which is characterized by your flushing, hypotension, and rash. Slow infusion and monitoring prevent complications. All right. It's given over an hour to prevent your red man syndrome. Definitely. All right. Are you concerned about any lab values when you're giving this patient this medication? Are you concerned about any lab values, trough levels? Okay. What levels are you concerned about? So I see you say trough levels. Anything else we're concerned about? Vancomycin level should be checked. Okay. Anything else? P, creatinine. Okay, definitely, because we know it is one of those nephrotoxic drug. All right. So creatinine, definitely. You want to keep an eye on that. All right. So it's nephrotoxic. All right. Nice. Okay. Alrighty. And ototoxic, toxic. Okay. Which other medication is ototoxic? That is antibiotic, another antibiotic. That is pretty common. They talk about for your NCLEX, gentamicin. Okay, nice, Sash, nice. Yes, Susie, your gentamicin. All right, Zosyn. All right, aminoglycosides, definitely. All right, mean old mycin. All right. Uh-oh. All right. A patient with a newly diagnosed hypertension is prescribed hydrochlorothiazide. Which electrolyte imbalance should the nurse monitor for? Yeah, no favor. We see it already. So, a patient with a newly diagnosed hypertension is prescribed hydrochlorothiazide. Which electrolyte imbalance should the nurse monitor for? Okay. So potassium B, hyper. Okay. All right. So hypokalemia, thiazide diuretics increase potassium excretion, which can lead to hypokalemia, increasing the risk of cardiac arrhythmias and muscle weakness. All right, so your hypokalemia. All right, you definitely want to do that. What class of drug is your hydrochlorothiazide? Diuretics, okay. Your thiazide diuretics. Thanks, Erin. All right. Besides, are not potassium sparing. They're wasting. Yes, potassium wasting. All right. A patient with cirrhosis has ascites and is receiving spironolactone. Which lab value should be monitored? A, serum potassium. B, serum sodium only. C, liver enzymes only. Or D, calcium levels. So a patient with cirrhosis has ascites and is receiving spironolactone. Which lab value should be monitored? Yes, your potassium. All right, your potassium. Not only liver enzymes or sodium levels. All right, you need all of those to be monitored. All right. A. All right, so serum potassium is a potassium sparing diuretic. All right, hyperkalemia is a major risk, especially in patients with impaired liver function. Yes, never pick only. All right, never pick any of the answers with only. And always use the process of elimination and answer your question. All right. All right, so we did this one. A patient has a blood transfusion reaction. Which finding requires immediate action? Fever, chills, and hypotension, mild pruritus, slight headache, low-grade temperature. Which one of them requires immediate action? All right, I see A. Okay, why that one? What are you thinking? So yeah, we'll stop infusion, okay? But why you need to go immediately to that patient? Based on the signs and symptoms, anaphylaxis febrile, okay? Anaphylactic, systemic reaction, all right? So the hypotension and febrile, all right? So because of the fact that the patient is having the hypotension there, all right? The patient is having an acute hemolytic transfusion reaction, which is a medical emergency requiring immediate cessation of transfusion and intervention. All right. So if it was just a pruritus, they can be having itching. All right, and nothing else not going on. Sometimes you just go ahead, shock or overload. You can have the itching, sometimes they'll probably, depending on what is going on, they'll go ahead and give their antihistamine. The slight headache as well, they might be having. All of those are showing, a reaction. All of those are showing reaction. But the one that is required for you to jump, and, is because of that blood pressure being so low. All right, and the fever with the chills. All right. All right, we already showed this one already. So a patient with pneumonia has a saturation of 88% on room air. What is the priority nursing intervention? Administer oxygen, encourage coughing exercise only, administer antipyretics, or D, encourage ambulation. I tell you, Oima, this is the first time I'm trying the, showing up on the screen there. So, yeah, I'm getting the hang of it. All right, yes, administer your supplemental oxygen. What is the normal oxygen saturation we're looking for? What's the range? And thank you for liking up the live. All right, remember to do your daily heart means. Hit that button, that heart button above my head. Yeah, it looks like the previous question. All right, 94 to 100 or 95 to 100? Greater than 94, definitely. All right. So 95 to 100 is what we're looking for. All of them answer yeah, A. Top tier. All right. All right. Oh, God. So oxygen saturation below 90% indicates hypoxemia. Prompt oxygen therapy improves tissue oxygenation and prevents complication. All right. All right. Let's see. Which intervention is priority for a patient with acute glomerular nephritis and edema? So which intervention is priority for a patient with acute glomerular nephritis and edema? Okay, what somebody's asking, what's the difference between hypoxia and hypoxemia? What's the difference between hypoxemia and what's the difference between hypoxia and hypoxemia? Uh, so okay, so low oxygen saturation, low blood levels, okay. All right, hypoxia is just the low oxygen, and the hypoxemia is the decrease in the oxygen in the blood. So hypoxia is a lack of oxygen to the tissue, and hypoxemia is a lack of oxygen to the blood. All right, so deficiency of the oxygen in the tissue level is the hypoxia. All right, and then both of them are related. All right, but they're different. All right. So hypoxemia is a low oxygen in the blood and low oxygen in the tissue, hypoxia. All right, definitely. All right, so the answer for, oh, I think you guys go on all the way up. All right, zemia is low oxygen in blood. Yes. All right. So answer is A. So which intervention is priority for a patient with acute glomerular nephritis and edema? A, monitor daily weight and fluids. B, encourage NCLEX-like questions. All right. I don't think anybody has the real NCLEX questions. So all of them are like NCLEX type questions. All right. So monitor weight at the same time. Okay, definitely. So monitor your daily weights and fluid status. Encourage high sodium diet. Administer IV fluids aggressively. Encourage prolonged activity. All right, so A, definitely you want to monitor your daily weights and the fluid status. All right, because when you have too much fluid, the edema is usually fluid retention. All right, so monitoring weight and fluid balance helps assess response to therapy and prevents complications such as pulmonary edema. All right, with a patient with acute glomerulonephritis, do they what their urine usually looks like? Roz says, can you turn the blue folder? Turn the blue, oh, let me push it up a little so you can actually see the, no, I can't turn the blue folder or else you're going to see the remainder of the question. Tea color, yes. Usually tea color, brown color, Pepsi looking color, anything like that. Yes, favor, Coca-Cola color. All right, it's usually what the urine usually look like. Nephrotic syndrome is Pepsi. All right, but the urine color is usually like dark. Can you turn the blue folder? Oh no. Nephrotic is blood. Nephritic, concentrated. Let's look at the nephrotic syndrome. nephrotic syndrome and glomerulonephritis. Let's look at both of those. All right, so glomerulonephritis, we know it's the inflammation of the glomeruli, the tiny blood vessels in the kidneys. All right, and the nephrotic syndrome is a group of symptoms caused by the damage to the glomeruli that results in significant protein loss in the urine. All right, so the key features of glomerulonephritis, as I say, one is inflammation of the glomeruli, goodness gracious, and the other, the nephrotic syndrome, is the damage to the glomeruli. All right, you have proteinuria, which is usually moderate to severe in the glomerulonephritis. All right, hematuria is often present in the glomerulonephritis. It is absent in the nephrotic syndrome. Edema is present in both, but it's usually significant, all right, in the glomerulonephritis. All right, often severe in nephrotic syndrome. Hypertension is common in glomerulonephritis, and it may be present in a nephrotic syndrome. All right. I was hoping that I would see something regarding. So, all right. So you have the hematuria, which is the blood in the urine for the glomerulonephritis. All right. And you also have excessive protein as well in the urine. All right. So I guess Michelle, I know me a laugh after. We can't manage. Oh Lord. All right. So eventually, so the T color should be fine. All right. The T color should be fine for them for their urine. All right. And then eventually you'll have the Pepsi color urine. All right. And they can combine, concentrated, and they can combine. Yes. All right. All right. So a patient with heart failure is prescribed lisinopril. What kind of drug is lisinopril? What kind of drug is lisinopril? And thank you for liking up the live, guys. All right. Let me drink some water while I not tap up the screen. Carousel, you're here. Oh my God, welcome back. All right, so it's an ACE inhibitor. ACE inhibitor, okay, nice. And how do you know it's an ACE inhibitor? And thank you for tonight's carousel. You know what we are talking about. Okay, nice, the Pril. All right, so you have a patient with heart failure that is prescribed lisinopril. Which side effect requires immediate reporting? Is it A, the angioedema, B, mild cough, C, fatigue, D, hypertension? All right, so C, A. All right, the cough, some persons are saying, but out of the cough and the angioedema, which one of them you'd be concerned about? Is it the cough still? All right, okay, somebody says the hypertension as well. Okay, cough is expected, so the cough can put away, and plus it's mild cough, so they won't die from that. All right, so let's go ahead and look at the others. Is it fatigue? Fatigue, you put a big X beside it. A is showing signs of anaphylaxis. Angioedema is life-threatening, so definitely you'll go and do that one, because hypertension can, you just give some fluid and pump that back up in terms of their, okay, so angioedema could lead to swelling in the throat, so definitely we would go ahead and report the angioedema. All right, so always remember, you still use your airway breathing circulation. Airway comes first. All right. So angioedema is rare but potentially life-threatening reaction to ACE inhibitors requiring immediate intervention. Susie says the hypotension. But out of the hypotension and the angioedema, which one are you more concerned about based on your airway breathing circulation rule? All right, so still use it as a guideline. Always use your nursing process, your ADPI. Still use your airway breathing circulation. Still use use the process of elimination even when you're working with those. And then from there, all right. All right. So the mild cough, as I say, just look at both of them and see, airway is always going to take preference. Airway is always going to be first in everything that you're doing. All right. Depending on the other options, then you can always look to see if neuro is something that needs to be addressed immediately, if there is any sudden changes and the other options that you have. All right. All right, so let's go. A patient with atrial fibrillation is prescribed warfarin. Which lab value is essential to monitor? Is it A, INR, B, serum potassium, C, BUN and creatinine, D, hemoglobin A1C? All right, so C, A. Okay, nice. All right, INR, definitely. All right. Serum potassium, BUN and creatinine, A1C. All right, and we already talked about A1C earlier. In terms of your BUN and your creatinine, which one is a true indicator for, like, how your kidney is doing? Which one would you go with in terms of, your lab value? BUN or creatinine? Creatinine, definitely, because your BUN can actually change because probably the patient is dehydrated. So you give the patient some fluids and usually that corrects it. But once your creatinine, once you have a slight change in your creatinine, then that's a problem. All right. So your creatinine is more important there. Serum potassium, still check that. But with your patient with your AFib, they're prescribed your warfarin, so you want to make sure you're keeping an eye on your INR. All right. Okay. So warfarin affects clotting. Monitoring INR ensures therapeutic anticoagulation while minimizing bleeding risk. Okay. Which finding indicates fluid overload in a patient with chronic kidney disease? A, bounding pulses and pulmonary crackles. B, dry mucous membranes. C, flat neck veins. Or D, hypotension. So which finding indicates fluid overload in a patient with chronic kidney disease? A, bounding pulses and pulmonary crackles. B, dry mucous membranes. C, flat neck veins. Or hypotension. Nice. Definitely your bounding pulses and your pulmonary crackles. All right. Will this patient have like dry mucous membrane? If you have a patient that is fluid overload, are you expecting their mucous membrane to be dry? No, because they have volume of fluid to moisten, so it won't be dry. So fluid overload increases vascular volume, causing elevated blood pressure, bounding pulses, and pulmonary congestion. All right. So flat neck veins, no. All right. This patient is gonna have the distended. All right, because you're gonna see there's a lot of fluid. All right, they have a lot of fluid, so they'll have the distension there in their neck veins. Hypotension. Will this patient have hypertension? Yes, the dry mucous membrane indicates dehydration. Nice. All right, no. Will this patient have hypotension or hypertension? Hyper? And someone says no. Chronic kidney disease causes hypertension. Okay. Hypertension. All right. Michelle, you says hypotension. Why? Okay. All right, nice. So you have a patient that has, so for example, you have a patient that has dry mucous membrane, or let's say, what are the expected finding for your pediatric? You have a pediatric child that comes in and you're suspecting dehydration. Apart from the dry mucous membrane, what other signs, or what other signs you can have for this in terms of your assessment? What are you looking out for your pediatric patients with dehydration? Sunken eyes. Okay, skin turgor. What about their skin turgor? Can't find their vein. Okay, sunken eyeball. Are they going to be having like bulging fontanelles or sunken fontanelles? Prolonged capillary refill, increased skin turgor, decreased saliva. Okay, nice. Stenting, sunken fontanelles. Nice, nice, nice. All right. And what about their urine? They probably have decreased urine output. All right. Dry diaper. Yeah. So sometimes the parents probably come to you and tell you that, oh, they've been feeding, but the baby hasn't been peeing, or the baby is crying in front of you, and you realize that this baby not putting out any tears, or the cry is just weak. You're probably poking this baby and the baby is not crying any at all because the baby is just so weak. Always suspect your dehydration, especially if they say that they're vomiting, they're having diarrhea. Yes, they're limp. Nice. All right, so suspect all of those. When you look at your patient or the child, just think of dehydration and try to get that corrected. All right. All right. So you have a patient with a history of myocardial infarction who reports sudden severe chest pain radiating to the jaw and the left arm. What is the nurse's priority? A, activate rapid response for code and prepare for ECG. Give antacids. C, apply warm compress to the chest. Or D, encourage ambulation. A. Nice, nice. Activate the rapid response or code and prepare for ECG. All right. So with a patient that has a myocardial infarction, all right, how do you go about with treating this patient? What are you anticipating in terms of for the treatment apart from the ECG? Okay, Mona Lisa, Michelle. Nitro, oxygen, nitro. Okay, oxygen. All right, Michelle is coming with Mona Lisa. Okay. Aspirin. All right, Michelle said aspirin. Okay. Onam. If it's a STEMI PCI, definitely. All right, so definitely you're thinking about your Mona, your morphine, your oxygen, nitroglycerin, and your aspirin. All right. So you give this patient, your aspirin per order. Not your aspirin, your nitroglycerin. You give the patient the first nitroglycerin and the patient is still having chest pain. What's next? So you give the patient a nitroglycerin, the patient says, oh, nurse, I'm still having chest pain. Okay, we already called rapid response. All right, you give another. How many nitroglycerin are we giving? 5, 10, 15, 20. Okay, yes, we'll give the oxygen. Nice. We can give up to 3 doses of your nitroglycerin. How much minutes apart? Give it 3 times, up to 5. Up to 5 with ROZ, 3 to 5 minutes apart. Oh, 3, 5 minutes apart. Definitely. So the patient is still having the chest pain after you've given the nitroglycerin. What else can you do for the patient based on the orders that you have for your Mona? You give aspirin, clopidogrel, Ator, Clexane. Okay. What about your morphine? We still haven't given that as yet, so you can always go ahead and give your morphine, all right, based on your Mona there. Yes, all right. If you tell you, yes, Wagwan. Welcome. Yes, I'm from Jamaica. All right, I'm from Jamaica. Remember to go ahead and follow my page. All right, and if you're new here, thank you so much for tuning in. You can also follow me on, you can subscribe to my YT page at ThinkNursing. All right, it's the same name on the other platform on YT. And definitely follow me here on TikTok. All right, we do our questions on Tuesdays and Thursdays at 7 p.m. Should be a 1 hour class, but yeah, I'm not working tomorrow, so sometimes we go a little bit longer until people start sleep on the live. All right. Sleep going. Okay, Oyima, thank you. All right. All right, so we talk about your Mona. Okay, nice. So we talk about all of those. So if this patient is still having, is it okay for you to give the patient the antacid? Thank you, Sash. Thank you. Studying supposed to be like, fun. Talk to me direct. Okay. Okay. So what if this patient was having okay, no, it's for dyspepsia. Okay, nice. But what if this is an elderly person who was complaining? This patient was complaining initially that they're having heartburn. They're having heartburn, and you're thinking they're still having the I should leave. I'm a doc. I'm a doc. You're a doc? Okay, okay. Because I see you putting up some things there, and I'm like, okay, then some of these things are like new to me. But thank you, though. Thank you for tuning in. I appreciate it. Yeah, that's that. I appreciate it. All right. I appreciate you taking the time out. All right. But what if this patient was having like the heartburn and all? Would you think about giving this patient the antacid? No, okay, no. Denisha says yes. Okay. Why you give this patient antacid, Denisha? Top tier says no. Okay. All right. So no, I want to give this patient this antacid there. All right. Apply warm. Applying. Oh wait, including those symptoms. Yeah, including those symptoms. All right, applying warm compress to the chest. I wouldn't. I just thought it was just heartburn. Okay, nice. Encourage ambulation for this patient right about now. We wouldn't do any of that. All right, so you get the patient in bed, get the EKG on. You do based on your orders that you have, and then from there, what are you expecting on their EKG? I know somebody had said it earlier, said something. If this patient is having a true MI, what are you looking in terms of EKG changes on your EKG? You're looking for your ST segment changes, definitely. All right, you're looking. Top tier is asking how long I'm gonna be here. Funny enough, it depends. It depends on when the live, people start going. I'm not really sleepy right now, so and I'm enjoying this. I have 100 questions that are prepared. We're just at 50. So until I see people kind of saying bye, then I get the picture. Yeah, and once my hear Carousel says that she's sleepy, or he, Carousel, we've been talking, I don't know if you're a male or a female. So whenever the Carousel says, sleepy, then, we're cutting, we're leaving. All right. Because I'm running to get my daughter from work. Okay, that's fine. I'll be here. I'll be here. ST depression or ST segment ST elevation sash. ST depression. And T, so you come on every Tuesday and Thursdays night. Yes, I try to. I'm still here. Okay, okay, you're not sleeping. All right, that's nice. Okay, we're looking for the ST segment changes. So the elevation, I was looking for Sash. All right, ST depression, T wave inversion. Okay, all right. Cami says A. How many questions left? Oh, so I have 50 questions remaining. So I have 100 questions prepared. So it depends. You know, whenever the vibe cuts, then we can cut as well. So whenever the live is like very quiet, then I know that's the time to go to sleep. All right, but I try to prepare 100 questions so we can study together. Because honestly, I've been learning a lot. Me not lie. I've been learning a lot. Some of these are like refresher for me. Because some I remember from nursing school and, you know, you don't see it some days. So out of sight, out of mind kind of vibe. But I'm learning a lot. So thank you guys for, you know, popping in and making it so fun. All right. All right. All right, so we said that we'll activate the rapid response or code and prepare for ECG. All right, classic MI symptoms require immediate evaluation and treatment to prevent cardiac arrest or further myocardial damage. Champagne, you're here. Welcome, welcome. All right, finally here, but better late than never. All right. All right. So a patient with Parkinson's disease experienced dyskinesia after levodopa therapy. What's the nurse's best action? A, notify provider for possible dose adjustment. B, stop the medication immediately. C, encourage more physical activity. Or D, provide a high protein diet immediately. So you have a patient with Parkinson's disease that is experiencing dyskinesia after levodopa therapy. What is the nurse's best action? All right. And we see A. Shells, you're here. Welcome. All right. So we have A, notify the provider for adjustment to the dose. All right, so dyskinesia is a common side effect of levodopa, often dose-related. Provider intervention may include adjusting dosage or timing. Alphil said B, stop the medication immediately. All right. You want to stop the medication, you adjust the medication dosage. All right. Yes, not immediately. All right, nice. All right, so let's go on to, okay, all right. So a patient with hyperthyroidism reports palpitations and heat intolerance. Which lab result supports this condition? A, elevated T3 and T4, decreased T3. B, low T3 and T4 with an elevated TSH. C, normal T3 and T4, low TSH. And D, elevated TSH only. All right. So this patient has hyperthyroidism. All right, so we have here A, B, A, we have C, okay. All right, so what are we looking for in terms of for your thyroid? Okay, so we have so most persons are saying the elevated T3, T4, decreased T3, TSH. All right, C such says substance change normal T3 and T4, low TSH, heat intolerance. Yes, they do have that. All right, so definitely answer is gonna be the elevated T3 and T4. All right, with your decreased TSH rather, sorry. All right, so hyperthyroidism presents with high thyroid hormone levels, so your T3, your T4, and suppressed TSH due to a negative feedback. All right, so you can check the symptoms like your rapid heart rate. So the patients might have like rapid heart rate, They might have weight loss and they don't know why they're losing their, you know, their weight. Sometimes they have anxiety. All right, so definitely those numbers will be abnormal. Your T3, your T4, all right, will be elevated and your TSH will be low. All right. So for this patient, see hyperthyroidism. Okay. So elevated TSH only. So the normal T3 and the T4 with the low TSH. Who had said that up earlier? Subacute hyperthyroidism. Such a tricky question. For C, high T3. Okay, so you have to just know about your TSH and your different, your T3 and your T4, all right, and what the normal is, and then you'll be able to tell whether or not this patient is in subacute, if this patient is and then from there, so read on the normal levels and then ways to identify, you know, hypothyroidism and how you go about with managing them. All right. The hand tremors, yes. All right, because with this patient, the metabolic rate is high. So the patient tends to be a little bit thinner. And then with the hypothyroidism, you know, it's slowed down. So those patients tend to be constipated, you know, they're obese, things like those. And they have a lot of facial hair. All right. Which finding indicates worsening respiratory status in a patient with COPD? All right. So which finding indicates worsening respiratory status in a patient with COPD? A, PaCO2 of 65 and a SAT of 85. B, PaO2 of 80 and SpO2 of 95. C, respiratory rate of 18. And D, mild dyspnea on exertion. All right, so I have here AAA with a question mark. Okay, the CO2 of 65 and the SpO2 of 85. All right, and it says elevated CO2 and low oxygen saturation usually indicates respiratory failure requiring immediate intervention. What is a normal CO2 level? What's a normal CO2 level? PaCO2. CO2 is high. Yes. What is the normal CO2? 35 to 45. SpO2 you're looking for is? Yes, 35 to 45. What's the normal SpO2? Okay. Can it be ARDS too? $88 to $92, 90 or higher. 95%, 92 for COPD. It can go as far as 88. 88 for COPD. 80 to 100. Yeah, 80 is gonna be too low. Well, oh, for the you're talking about the SpO2. The normal oxygen saturation, 88 is pretty acceptable. Let's look up that for the CO2, SpO2 range for your COPDs. 88 to 92% is for your COPD. All right. So your SpO2 can be anywhere between 88 and 92% for your COPD patient. When is it too low for O2 for COPD patients? Anywhere below 88% because of their, yes, so 88 to 92% for COPDs because of their tidal volume. Okay, yeah. So anything above 88, you know, and we don't want them to be 100%. All right, we don't want them to be 100%. So we want them to be at least up to like your 92%. All right. And we said what was the normal range for your SaO2? It's gonna be your 95 to 100%. Did we say that? Okay, yeah, Chinoni says that earlier. All right, nice. All right, let's go over here. A patient with DVT, deep vein thrombosis, is prescribed heparin, which is a priority nursing intervention. Monitor for signs of bleeding and APTT. Encourage prolonged bed rest only. C, apply warm compresses only. And D, administer aspirin concurrently. So, a patient with DVT that is prescribed heparin, which is a priority nursing intervention, flooded with A's, monitors for signs of bleeding, and always monitor for your PTT, definitely. All right. So monitor for signs of bleeding and your APTT. All right. So heparin increases your bleeding risk. Monitoring your APTT ensures therapeutic coagulation, and bleeding assessment prevents complication. All right, so you have this patient that is on your heparin. What is your antidote for your heparin? What is your antidote? So you have this patient that has been getting too much heparin. What is your antidote? What is your go-to medication? Your protamine sulfate. Okay, nice. All right. Yes, protamine. The protamine sulfate, nice. So how often are you going to be monitoring the checking lab values for this patient? So you have this patient on the floor. How often are you going to be monitoring this patient's blood level to see? So you have this patient that is getting the infusion. How long are you going to be checking those? 30 to 60. Can I see the question, please? Oh, sorry. Oh, there you go. All right, 30 to 60, 5 to 50, 30 to 60. Okay. So usually once I start the infusion, like every 6 hours, I tend to, repeat the lab values to see what the PTT is. All right. And then from there. All right. So encourage prolonged bed rest only. No. All right. As I say, anytime you see any question that has only, eliminate that one. All right. So apply warm compresses only. No. You definitely want them to be on bed rest, but not prolonged bed rest. All right. Because you don't want to dislodge that clot. All right. Apply warm compress. Nothing is wrong with the warm compress, but that's not the only thing you're going to be doing. All right. And then from there, administer aspirin concurrently. I see sometimes providers do it. You understand? I sometimes see them do it. But the priority here is going to be for your monitoring for your signs and of bleeding. All right. What are some signs of DVT? What are some of the signs and symptoms of a DVT? Warm compress for infiltration. Yes, definitely. Swelling in the leg. Okay, nice. Anything else? Edema, pain in the calf area. Definitely Raymond. Pain. All right. Okay. Pain, swelling. Okay. Capillary refill less than 3. Redness, sometimes warmth. All right. All right. So if this clot gets dislodged and goes to the lungs, what do we call it? Bruising. Yeah, sometimes they have bruising there. So if it gets dislodged, go to the lungs, a PE. If it goes to the brain, that same one clot giving so much problem. If it goes to the brain, so if it goes to the brain, what is it? Aneurysm. All right. No, that's not what I'm thinking. Embolism. Yeah, it's an embolism. But it goes to the brain, aneurysm. Stroke. Remember stroke? All right. And if it goes to the heart, you have your MI, your myocardial infarction. Same one clot moving all over, giving problems. All right. Okay. All right. So we'll do the brain. We'll do that one. Okay. Which patient is at highest risk for pressure ulcer? A, immobilized patient with poor nutrition. B, active patient with diabetes. C, patient with mild fever, or D, ambulatory patient with mild edema. So which patient is at highest risk for pressure ulcers? Cerebral thrombosis. Definitely oedema. All right. So AAA, immobilized patient with poor nutrition. Okay. Patient needs to be turned or ambulate. Okay, definitely you need to turn that patient. All right. So immobilized patient with poor nutrition. All right. So pressure ulcers develop from prolonged pressure, friction, and poor tissue perfusion, worsened by malnutrition. All right, so you definitely want to make sure you're turning this patient frequently. All right, making sure that they're eating a protein-rich diet. All right, you have an active patient with diabetes. Is a patient at risk for pressure ulcer? No. Okay, because that patient is active. All right. That diabetic patient, what is that diabetic patient at risk for? That active diabetic patient every hour? Yes, it turn them every hour. All right. What are some risks that the diabetic patient is at risk for? What are some things that your diabetic patients are at risk for? 1 or 2 hours, yeah. Neuropathy, definitely. All right. Wound development, yes. Okay. Retinal detachment, retinopathy. All right, so all of those, hypoglycemia, definitely. All right. Poor wound healing, nice, nice, nice. All right. Infections, nice. All right. So you have a patient with asthma, amputation. So you have a patient with asthma that has a peak flow reading of 120. All right. Their personal best is 400 liters per minute. Which action is priority? A, administer rescue inhaler immediately. B, encourage walking. C, administer long-term controller only. D, document and continue monitoring. So you have a patient that has is asthmatic and the peak flow is 120 liters per minute, but the patient's personal best is 400 liters. What is your priority action here? Bronchodilator, definitely. So A. All right, so you always want to go ahead with your rescue inhaler immediately. All right. Inhaler, A, okay. In terms of your peak flow, what is the normal range you're looking for your peak flow? $300 to $500. Okay. No, you don't know that one. So $300 to $500, I think it's for females. And then for the males, it's a little bit higher. Like $400 to $700 thereabout for males. All right. But then just always look on the thing. Just look on the spirometer and you'll see green. You know, green means good. And you just look at it, have them blowing it. Then from there, we don't know if they are in distress. So why not C, administer long term? So C, if they're in distress long term. All right. So C, even if the option never had only, as you say with the only question, you know, with the only question, you always eliminate it. All right. But administer long-term controller, they'll be on long-term controller, but this patient is distressed based on the fact that they're at a 120 right now. All right. So you need something that is going to be working right now. So you're going to give that rescue inhaler. All right. Long-acting patient needs open airway. Yes. Yes, it's only because of the only. All right. The patient is going to be eventually on it, but the long term is for long-term maintenance. All right. It's going to be more for maintenance. You need something that is going to work immediately, which is going to be your bronchodilator, which is usually your rescue inhaler. All right. All right. So a peak flow less than 50, personal best indicates a severe asthma exacerbation. Immediate intervention is required to prevent respiratory failure. Okay, I'm just used to the question saying dyspnea or something. Got it, thank you. Not a problem, not a problem. All right, albuterol, right? Yes, albuterol, any bronchodilator, then they'll definitely be using that. All right. A patient is prescribed, okay, so we already know this one, but just in case the persons who answered it, you know, are not here, let's go again. A patient is prescribed furosemide for heart failure. Which electrolyte should the nurse monitor closely? A, potassium, B, calcium, C, phosphate, D, magnesium. And everybody's saying A, because we're A students. Definitely the potassium. All right, because furosemide is what kind of drug is potassium? Not potassium, the furosemide. It's a diuretic, okay. Water pill, diuretic. Poo. Yeah, your loop diuretic. So, okay, so new, it's a loop diuretic. Now I get the 8 answers because we are exactly, Oyema. Exactly. All right, so it's a loop diuretic. All right, so you have a lot of, it increases your potassium excretion. So you are at risk for hypokalemia. All right, I think I see somebody was saying potassium sparing. No. All right. Okay, so you lose a lot of potassium with that. So it's potassium wasting. All right. Oh, so yes, she corrected herself. All right. So this patient is at risk for hypokalemia. All right, which can cause your cardiac arrhythmias. What are some other diuretics you can think of? Like another loop diuretic that we have out there that is similar to your furosemide. Your Biomix, okay. You have your torsemide as well. All right. All right. You have a patient with amphotericin. Can't spell. Hydrochlorothiazide. So your hydrochlorothiazide is what kind of drug? What kind of drug is hydrochlorothiazide? It's a diuretic. Wasting diuretic. Okay. All right. Let's move in. Thiazide diuretic. Nice. All right. So we're saying A. So you have a patient who is receiving antifersin, developing fever, chills, hypotension during infusion. What should the nurse do? Stop the infusion immediately. All right. I think I see a ton of A's flooding here. Nice. And then the questions just seem like all of them just A. All right. So stop the infusion immediately. Definitely. All right. Amphotericin B can cause severe infusion reactions. Stopping the infusion prevents further complications, followed by notify the provider. All right. So amphotericin is a potent broad-spectrum antifungal medication primarily used for treating serious life-threatening fungal infections. Due to its toxicity, Its use is typically reversed or reserved for severe cases of or patients who cannot tolerate newer, less toxic antifungals. All right. So it is a polyene macrolide antibiotic that targets the cell membrane of fungi. All right, I've never treated anyone with that. Okay. All right. So we definitely want to stop the infusion and notify the provider. All right. And as I say, always use the process of elimination when you're answering the question. You can also use, true or false and say, oh, exactly. Ketonazole. I know, right? But it's not it's not a drug that is commonly used. So, you have to pre-med, then post-med. Okay, okay. Yeah, as I say, it's not something that is commonly used, and they say it's reserved for persons who are not able to tolerate, the other drugs. Okay. You have to pre-med and then post-med. All right. A patient with CHF has, it's known as terrible B. Okay, okay. And for the NCLEX, they're not going to be using a lot of the newer drugs on the exam. It's usually the older ones. I thought you were in Peloton. No, I'm not tonight. RN to CEO. Welcome, welcome, welcome. All right. So a patient with CHF has weight gain of 3 pounds in 2 days and swelling in the legs. What should the nurse do first? All right. A, assess fluid status and notify provider. B, increase diuretic dose independently. C, encourage bed rest only. D, document and continue care. All right, so AAA, which is assess fluid status and monitor provider. All right, so always assess. All right, so 3 pounds in 2 days is a pretty decent amount. All right, with the swelling in the legs for anybody. All right. So assess the fluid status and monitor the provider. Rapid gain weight and edema indicate fluid retention, requiring prompt assessment and potential adjustment to therapy. All right. Increase diuretic dose independently. No, we're not going to increase anything. We're not going to adjust anything because we're not doctors. You understand? So we'll get the orders and then adjust it as per order. All right. Which patient require, we know this is tuberculosis because the answer is there. Which patient requires airborne precaution? Patient with active tuberculosis, the influenza, MERS, or cellulitis. All right. What will be your precaution for your influenza patient? Droplet. Okay. Your MRSA patient is going to be what kind of precaution? Yes, it's going to be droplets. Nice. Okay, your MRSA is going to be your contact precaution. Nice. Okay. All right. And cellulitis, what kind of precaution you'll do for cellulitis? Your standard precautions. Contact. All right. Okay. So what's the standard precaution? What are the PPEs you'll use for standard precautions? Gloves and mask. All right, so gloves, definitely for your standard precaution, you'll just do your gloves. All right, your contact precautions. All right. What will you use for your droplet precautions? What PPEs you'll use for your droplet precautions? Gloves, gown, mask, yes. Okay. And then your N95, who do you... Mask, gowns, glove. Okay, nice. So for your droplet precautions, do you need your N95 or do you just need a regular surgical mask? Regular mask, surgical mask. Okay, nice. Okay, and TB is for your N95. Nice. Okay. I think I see a question regarding diphtheria. Okay. Someone was asking about diphtheria. All right. So for diphtheria, you definitely want to go ahead. What do you use for your precautions for your diphtheria patients? Do we do droplet? Do we do airborne for those patients? For your diphtheria patients, what do you use for your precautions? Do we do droplet? Do we do airborne or standard? So, okay, so it can be the droplet and the contact. All right, so droplet until you get back your results. All right. Yes, so always just go with the droplet for your diphtheria patients. All right, because it is very contagious. So you want to make sure you do your strict isolation for those patients. When you get back your results and if it comes back and it's negative, then you can always, do your regular precautions for them. All right. If there are lesions, if they have lesions and the lesions comes back and it's negative, then, you just do your regular basic precautions, your regular standard precautions. All right. Still here. I went to Seasoned Chicken and couldn't find you. You couldn't find me? Oh, my word. I am still here, dear Denique. Welcome back. Welcome back. Remember to go ahead and tap up the live. All right. Like up the live, share it, and welcome, welcome, welcome. I'm Stacy. All right. Thank you for tuning in. All right. So let's go on to, okay, so for the TB patients, TB is transmitted via airborne droplets requiring negative pressure isolation to prevent the spread of the infection there. What are some medications that you would be anticipating for a TB patient, a tuberculosis patient? What are some of the medications you're anticipating for your tuberculosis patient? Ripe, okay, all right. Tell me about Ripe USA for Life TikTok and Favor. Rifampin, okay, I forget about they make secretions, okay. Parazina, okay. Your isoniazid, your your ethambutol, isoniazid, okay, rifampin, pyrazinamide, nice, 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 okay. All right. Is it something that the patient is going to be on for short term or is it a long-term treatment they're going to be on? Are they going to be on it for a week or two or how long are they going to be on it? The medication? Long term. Definitely they're going to be on it for long term. All right. All right. Is there anything you want to tell them about any other medication? I see somebody had said something regarding secretions and color. Which one of the medication you're going to tell them about that has a specific color that they're going to be seeing and that they shouldn't be freaking about? No contacts, okay. All right, orange rifampin. Okay, nice. Yes, so they're gonna be on it for a long term. All right. So the rifampin changes their color to orange. So let them know from ahead of time so that way they don't discontinue the medication because their urine is too orange. All right. All right. Nice. And ethambutol, watch for the eye. Okay. Check sign for they are all hepatotoxic. Yes, Oyema, they are all hepatotoxic. So know the medications that are toxic to the liver. All right. Always try and remember those. The ones that are gonna cause any liver problem, kidney problem, anything that affects any of the major organs. Know those medications. All right. For the exam. So a patient with chronic kidney disease has hyperphosphatemia. Which intervention is appropriate? A, administer phosphate binders with meals. B, encourage high phosphate foods. C, restrict fluid only. D, monitor for hypokalemia. So you have a patient with chronic kidney disease that has hyperphosphatemia. Which intervention is appropriate? A, administer phosphate binders with food. B, encourage high phosphate foods. C, restrict fluid intake only or monitor for hypokalemia. All right, Hail Marcus, welcome, welcome, welcome. And we all says A, nice. Phosphate with meals, you want to go ahead and administer that. All right, so phosphate binders reduce absorption of dietary phosphates, preventing complications such as bone demineralization and secondary hyperparathyroidism. All right. Yes, your phosphate binders. All right. All righty. So a patient with hyperkalemia, the potassium is 6.8 milliequivalent per liter. All right. Not a problem, Roz. Thank you so much. Thank you so much for joining in and for following. All right. So you have a patient with hyperkalemia, 6.8 is the potassium. The patient is asymptomatic. Which intervention is priority? A, place the patient on the cardiac monitor. Oh, Jesus. Why am I always... Placing the patient on the cardiac monitor. B, encourage high potassium foods. C, administer IV fluids only. D, notify the family. And we say A because it's right there because it's at, they're at risk for this dysrhythmias. All right, so the normal value is 3.5 to 5. And let's hear again, because probably some persons are still sleeping. How do you treat your hyperkalemic patients? What medications you're anticipating? How do you treat hyperkalemia? And if you, okay, all right, nice. Your insulin, your calcium gluconate, your NCLEX rate range is 3.5. Yes, we have the peak T waves, definitely. And all of those things. All right. K-oxalate, definitely. All right. Is there any order? Is there any specific order if you were supposed to give this medication? Is there any specific order you'd want to give these medications in, or it doesn't really matter? And what about the glucose? You guys totally forget the glucose as well. I see insulin, but we don't see any glucose. Is there a specific order you're anticipating, you're planning on giving these medications in, or it doesn't really matter? Infusion, give insulin with dextrose. Okay. All right, so you're at the bedside. Imagine you're at the bedside. Is there any order that you definitely want to give these medications in, or it doesn't really matter? Okay, all right. So let's see what we have here. So give insulin with dextrose. All right, so we're gonna do infusion, regular insulin, IV calcium gluconate, then insulin potassium shift IV first. Dextrose calcium first to stabilize. Okay, so leading novation. Okay, nice. So you go ahead and start your calcium to stabilize your heart rate. All right, or stabilize your heart, definitely. So yeah, we're gonna put the patient on the cardiac monitor first. Then calcium gluconate, okay. All right, then which one? So why calcium gluconate? Yeah, so you're protecting the heart, all right? You're protecting the heart with the calcium gluconate. All right, so we have the patient on the cardiac monitor. You give the calcium gluconate. So after you give the calcium gluconate, what else are we going to be giving? So after you give the calcium, you want to go ahead with your insulin, your glucose. Which one? Okay. Who's a furosemide? Alpha. So after your calcium, okay, you do your insulin and your glucose, all right? Because you want to shift that potassium into the cell to lower your potassium level. All right, nice. Then 10 units of regular insulin. Depends on what the order says. All right, Bluebird. All right, so calcium, insulin, glucose. Nice. That's the order I'm looking for as well. All right, so you give the calcium first because you want to protect the heart. All right, you want to protect the heart. Then you give your insulin and then your glucose. All right, so you give the IV insulin with the D5. Yes, all right. And then you're anticipating that sometimes when you give the insulin, not sometimes, when you give the insulin, the glucose is going to drop. So even so, when you give the dextrose, that is also going to help with making sure that the patient doesn't go hypo. All right, hypoglycemic. All right. So yeah, but it acts as a like what do you call it now? It's like a transport. It's like a transport system. Just think of it. It's something that is helping with moving the potassium. All right. So you stabilize your heart first, and then after you go ahead with all the other things. All right. Would this patient, if you have a patient that is that has hyperkalemia, would they benefit from any albuterol? Would they benefit from any nebulizer treatment? If you see the doctor order that, would you question them like, hey doc, but this patient is not asthmatic, why are you giving this patient albuterol? Would you question it? So lead innovation says no. All right, so Mel says you want to question it. Okay, all right. So I see a few persons says no. Why you will not question it? Alfie says yes for tachycardia. Okay, well, all right. So they are beta agonists. Not sure, it has no indication for that condition. It can help with reducing the potassium as well. All right. It helps with shifting. All right. So sometimes providers will go ahead and add it. All right. It's a beta agonist. So sometimes they will go ahead and add it to help with the insulin. All right. To help with that potassium shift. It will cause tachycardia, definitely. All right. So even if the patient is not hyperkalemic, even your asthma patients, it does cause tachycardia. So you just have to monitor them. But sometimes, you know, especially like your renal patients, yes, it helps with the insulin for the potassium shift, definitely. So sometimes like your renal patients, sometimes their potassium is like so high, you know, they will go ahead and add the albuterol to it to help with that. All right. And then you can think about your K-oxalate as well. It helps to excrete potassium by the kidney. Yes. All right. All right. So that was that one. Continuous cardiac monitoring is first priority. All right. Okay. Would you get an EKG for this patient? The patient is asymptomatic. Would you get an EKG, or would you just put them on a cardiac monitor and just, keep monitoring them? Would you think about doing an EKG for them? Or you don't think it's important? You put them on the cardiac monitor, get the EKG. Yeah, okay. So you get the EKG just for like baseline. All right. So at least get a baseline EKG and then from there. All right. It is important. Nice, Favor. All right. 62. Amor says 8. Look for ischemia and PT wave. Don't expose answer. I am trying, but this thing here. All right. A patient with COPD is using a new inhaler. Which statement indicates understanding? A, I will rinse my mouth after each use to prevent infection. B, I can skip the inhaler if I feel fine. C, I will take rapid, shallow breaths while using it. I do not need to shake the inhaler before use. A. All right. So I will rinse my mouth after each use to prevent infection. All right, so let me push it slowly up. Okay, so you want to make sure we're not developing any oral thrush. So rinsing prevents your oral thrush. A common side effect of inhaled corticosteroids. Proper technique improves drug delivery and reduces complications. All right, I can skip my inhaler if I feel fine. Is that something that you encourage them to do, or do they need their inhaler whether or not they're feeling fine? No, definitely. I will take rapid shallow breaths while using it. No, I do not need to shake the inhaler before using it. You definitely need to shake it. Depends on the inhaler. Okay. All right. So they definitely need to shake it. Asthma may be not COPD. Yeah. They need to take it as prescribed. Yeah. All right. A patient has a new ileostomy. Which finding is abnormal and requires immediate intervention? A sudden cessation of output and abdominal pain. B, watery stool as expected. C, mild peristomal skin redness. Or D, small amount of mucus in the stoma output. All right, so you have a patient that has a new ileostomy. Which finding is abnormal and requires immediate intervention? All right, so sudden cessation, okay. All right, so CA, sudden cessation, A, definitely. What are you thinking about? Why you choose A? All right, so because it says sudden, what's happening there? What are you thinking? Gastroparesis, obstruction, possibly obstruction, you're thinking. All right. So if you have a person that the ileostomy was working and you realize that it just stopped overnight, you go back in the room and you don't see anything draining, or in the next few hours you don't see anything draining, you're thinking probably the patient is constipated or the patient has an obstruction, and especially with the patient having abdominal pain as well. All right. So abrupt absence of output with pain may indicate obstruction, ischemia, or stoma complication requiring urgent evaluation. Stop. So there is a blockage and the sudden pain isn't a good sign. Definitely. Sudden cessation means new onsets. So an obstruction, paralytic ileus. Definitely. All right. So definitely. So if this patient is having an obstruction, what are you anticipating apart from the abdominal pain? What else are you thinking going on with this patient? Okay, so the paralytic ileus hemorrhage. Why are you thinking hemorrhage, Mel? Pull it down a little. Notifying the provider. Okay. Obstruction can cause rigidity. All right. Nice. Okay. Yeah. So if you notice that the abdomen is rigid, it's firm, you know, they have abdominal pain. Okay. All right. What are you thinking as well? Uh-oh. Uh-oh. Let me fix this thing. Oh, 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 oh. What are you thinking? So we have the paralytic ileus there. Is it correct? Fixed properly? Okay. Peritonitis, definitely. Oh, but don't use that to answer the question, no, Samina. All right. Don't use that to answer the question, no. All right. Peritonitis, definitely. All right. So definitely. All right. Would you be feeding this patient if you suspect that this patient is having peritonitis or paralytic ileus? Are you planning on feeding this patient? The patient says, "Nurse, I'm hungry. I need a turkey sandwich and an orange juice." What we doing? Okay. But you're not gonna get a good score on your, you're not gonna get a good score. You're not gonna get awarded for, your, what else some the name again? The Daisy Award. You're not gonna get no Daisy Award because you never bring the patient the turkey sandwich and the orange juice. Yeah. Okay, so definitely we're not going to keep this patient. We're not going to give this patient anything to eat or drink. Patient is going to go, Daisy, yeah. Definitely keep this patient NPO, all right. And prep this patient for possible surgery depending on what's going on, all right. All right. So let me take my little time and go down. NPO monitor intake and output, definitely. All right, so see. I can't manage them questionnaire. All right. It's not me, it's the computer. But anyways, a patient with atrial fibrillation on warfarin reports black tarry stools. What is the nurse's priority action? All right, you have a patient that is on warfarin. The patient has atrial fibrillation and the patient is now having black tarry stool. What is the nurse's priority action? Favor. A, hold the warfarin and notify the provider. B, encourage more fiber intake. C, document and continue routine care. D, administer antacid. But the good thing about this is, we're learning. We're not doing just the multiple choice and just leaving it there. All right, so we'll forget about the ABCs over that side. All right, so the answer is, we say A again, hold the warfarin and notify the provider. What are you thinking about what? So this patient is on warfarin. Patient is having black tarry stool. We're thinking about a GI bleed. Definitely. Are we thinking about upper or lower GI bleed? So yes, the patient is at risk for bleeding. Nice, definitely. Okay. Upper GI bleed. Why do you say it's upper GI bleed? How do you differentiate between the upper and the lower? All right, so we have the melena, okay. The black stools, okay. How does it come about being black? Mixed with acid, yes. All right, so when the blood comes in contact with the hydrochloric acid, you tend to, or the gastric juice, you tend to have, the change in the color, which makes it black. And then Favor is saying when it is bright red, it is lower. Nice. All right, so you hold the warfarin and notify the provider. All right, so you have a patient that has a GI bleed. What are you anticipating in terms of the management for this patient? You monitor INR. Okay, nice. Next, serum infusion, your PPIs. Check H&H, anticoagulant, vitamin K. Okay, nice. Okay. Yeah, because the PPI, you want your vitamin K fluids. Okay. All right, nice. And your vitamin K. All right. Are you anticipating putting in an NG tube for this patient? Plus or minus? No. Mel says no. Bluebird says yes. Monitor for signs of shock. Okay. All right. So Anna says no. Upper GI NG tube. Okay. Definitely. All right. You're anticipating a GI a NG tube for this patient. All right. If this patient as tells you that they have a history of esophageal varices. All right, this patient has a history of esophageal varices. Will you go ahead and still put that NG tube in for this patient? Amora says no. Okay. All right. Okay. Why you want to put the tube in, but the doctor put the order in? Why you want to put the tube in? Why you want to put the NG tube in? This patient has a bleed, upper GI bleed, and the doctor puts the order in for the NG tube. Why you want to bother to put the NG tube in? What are you concerned about? Risk for more bleeding? Yes. Because you might just be inserting that NG tube and rupture that, that varices that they have there. So you don't want to cause further bleeding for that patient. All right. Easier to rupture. Definitely. Don't want to rupture it. Yes. All right. Say all the warfarin, black tarry stools indicate gastrointestinal bleeding, a life-threatening complication for anticoagulated patients. Immediate intervention is required. All right. A patient with hypovolemic, we're not going to look at A, B, C, or D, all right? But yeah, you have to write the answer there. A patient with hypovolemic shock has blood pressure of 80/50 and a heart rate of 135. Which intervention is priority? A, rapid IV fluid replacement. B, apply warm blankets only. C, administer antipyretics. Or D, encourage oral fluids. All right, yes. Why are we putting in the NG tube for that patient? So the patient with the upper GI bleed, why are we putting in the, someone is asking, why are we putting in an NG tube for that patient? Okay. All right, so Marisol is asking, why you want to put that NG tube in for the patient that we had earlier with the upper GI bleed? Decompress the stomach. Yes, so I want to get rid of all of that blood, decompress the stomach down there, and yeah. All right, Marisol. All right, not a problem. I was just, oh, you were just on UWorld. Okay, not a problem. Was taking a break, fluid replacement. All right, so the patient with hypovolemic shock and a blood pressure of 80/50, heart rate 135, which intervention is priority, is the rapid. Oh, Melly, you're taking NCLEX next week? Okay, I know you're going to do well. All right, I know you're going to be doing well. All right, congratulations in advance on your RN license. All right, speak it into being. All right. Oh, Alphil, you're doing yours next week as well. Congratulations. NCLEX in January is Denique. Okay, nice. All right, so we have some time for some persons. And the ones that are going to be doing their exam next week, me know already long time. You understand? I know already long time. All right. Girl, back to the question. Tokila. You know, use the door. All right. So patient with hypovolemic shock has a blood pressure 80/50 and heart rate of 135, which intervention is priority. All right, it's definitely gonna be your answer A. You want to do the fluid replacement. All right, definitely want to do your rapid fluid replacement for this patient. So hypovolemic shock results in inadequate perfusion, so fluid replacement is important. All right, so rapid fluid resuscitation restores circulating volume and tissue oxygenation. Oh, it results in inadequate perfusion. Yes. All right, so definitely that is what you're going to do for that patient. All right. So you get your large bore IVs and you start your IV fluids. What IV fluids you would be anticipating for this patient? Which IV fluids you're thinking about? Which one do you think would be best for this patient? Yeah, your isotonic fluid. All right, crystalloids, lactated ringers, 0.9 or LR. I would go with the 0.9. I would go with the 0.9, the normal saline. All right. For your lactated ringers, normal saline, yes. All right, your lactated ringers are best suitable for which clients? What patient specifically? If you have a patient coming in with certain condition, who would you go ahead and give the lactated ringers? Yes, you'll definitely go ahead and give your burns patient your lactated ringers. All right. All right. Oh, Jesus. Sorry, so we know this one. Patient with pneumonia prescribed IV antibiotics. Which intervention is most important? Administering the antibiotics at the prescribed time. All right. Encourage ambulation. Provide antipyretics only. Encourage oral fluids. And as we say, any question or any answer that has the option only, just eliminate them from the scenario. All right. And then from there, you can do your yes or no with that one, those two. All right, and then for your pneumonia, we say you always go ahead and get your blood cultures and then you start your antibiotics. Alfie says encourage ambulation. B. Are you sure, Alfie? So you have a patient with pneumonia, is prescribed IV antibiotics. Which intervention is most important? A. So definitely antibiotics at the prescribed time is what you definitely need to prioritize. They can ambulate, you know, but that's not priority right about now. All right, no ambulation until treatment. Because it's pneumonia, the patient is already receiving antibiotic. Yeah, because it's pneumonia. That's most important. But what's most important? Giving the patient the antibiotic or ambulating? You want to make sure that they're getting it at the prescribed time. All right. Encourage oral fluids only. You still encourage oral fluids, you know, but that's not priority. I take it back. Yes, antibiotic on time. Priorities are important, and important is the same. All right. So definitely. So timely administration of the antibiotic is crucial to treat the infection effectively and prevent progression or resistance. All right. A patient with cirrhosis develops confusion, asterixis, and lethargy. Which lab value should the nurse review? You have a patient with cirrhosis. All right, which lab value will you be reviewing for this patient? A serum ammonia, BUN, creatinine, or the sodium level? All right, your ammonium. All right, definitely. And what medication you're anticipating for this patient? Yes. All right, you're thinking about your encephalopathy, high ammonia causes, asterixis. All right. All right. BUN, creatinine are more for your kidneys and sodium as well. All right. Then from there. All right, so elevated ammonia is associated with hepatic encephalopathy, identifying and treating hyperammonia anemia prevents worsening neurological symptoms. What medication? You can do your lactulose for this patient. All right. Lactulose. TULOSE. Patient with diabetes ketoacidosis has a potassium 5.5 and is starting therapy, insulin therapy. What is the priority nursing action for this patient? To monitor the potassium closely, administer potassium restriction diet, encourage oral fluids, or hold insulin. Yes, you can do the albumin as well, favor. All right, for your cirrhosis patient there. All right, so AA can't hold insulin if it's DKA, or even if it's not DKA, can withhold the insulin. All right, what time does the session end? Anytime, you know. Usually I'll go, I'll try to finish by, I would say, we normally do probably like 4 hours, depending on the amount of persons that are on the live, because most of the time we don't finish the 100 questions. So it depends. I'm not working tomorrow, so I usually just stay up until 11. What time now? 11? Okay. All right. So you can't withhold the insulin if it's DKA. Potassium and insulin loves what's that? You adjust the fluids based on the potassium. All right. So you monitor your potassium closely. All right. Insulin drives potassium into the cells, risking hypokalemia. Frequent monitoring and replacement as needed is critical. All right. So you have the DKA patient. Potassium is 5.5. The priority nursing intervention is to monitor your potassium closely. All right. A patient with an NG tube for suction has sudden dyspnea and hypotension. What complications should the nurse suspect? A, aspiration or fluid electrolyte imbalance. B, mild dehydration. C, constipation, abdominal bloating. So, if a patient with an NG tube, I'm gonna go up to 70. I'm gonna go up to 75 questions. Patient with NG tube for suction has sudden dyspnea and hypotension. What complication should the nurse suspect? A, aspiration or fluid electrolyte imbalance. B, mild dehydration. C, constipation. D, abdominal bloating. C, assess airway first. Okay, aspiration. So aspiration or fluid electrolyte imbalance. All right. So the NG tube complications include fluid shifts, electrolytes disturbances, and the risk of aspiration. Sudden hypotension and dyspnea may indicate serious complication requiring immediate intervention or attention. All right. A patient with multiple fractures has decreased breath sounds and tracheal deviation to the right. Which intervention is priority? Prepare for chest tube insertion, administer pain medication only, encourage coughing and deep breathing, elevate the head of the bed. All right, so are you preparing the chest? So yes, prepare the chest tube Prepare for chest tube insertion. All right. If you have multiple fractures on one side of the chest, all right. If you have multiple rib fractures on one side of the chest, what is that called? If you have 3 or more fractures, what is that called? On the same side. Yeah, we prepare for chest tube insertion. So if a patient comes in and they have 3 or more uni something, if they come in and they have 3 or more fractures, rib fractures, atelectasis, no. Compound fracture, no. What about the flail tension pneumothorax, no. Where you have the flail chest, where you have multiple fractures, rib fractures. I said flail. Oh, I didn't see that. Sorry, Bluebird. I didn't see it. Sorry. All right. Yes. All right. So you have the detachment that is taking place there because of the multiple fractures on that side. All right. So usually, all right. So usually when you have blunt trauma to the chest from like motor vehicle accident, fall from heights, sport injuries, crush injuries. All right. You tend to have that. My comment's not showing. Oh, gee. Sasha. I'm seeing your comment, Sasha. Oh, gee, Sasha. I see your comment a while ago. All right. So, all right. So you have a patient with multiple fractures. So you definitely go ahead and prepare for your chest tube insertion. All right. I can see. Yeah, I'm seeing her comments. All right. So you'll definitely give them pain medications. But as I said, pain medication only, you eliminate that. But they're definitely going to need their pain medication. Encourage coughing and deep breathing. If you have a patient with tension pneumothorax, are you thinking about, coughing and deep breathing exercises right now for this patient? No. Okay. All right. Elevate the head off the bed. Not at the moment. Definitely not at the moment. All right. Especially if they have like the multiple fractures, they're going to be at risk for so much. They're going to be in so much pain. All right. So, you can't really have them be doing that much of a breathing in and, doing so much work there. So you have to make sure you load them up with their pain medication and make sure they're comfortable. So once they're exhaling, inhaling, it's not that painful. No, that's gonna hurt. They're gonna need pain medications. Yes, and a lot of times the patients with flail chest, they tend to be intubated because of that paradoxical movement that they have with their breathing. All right, and they're in so much pain. So a lot of times those patients end up getting intubated. All right. So you prepare for chest tube, your tracheal deviation, and the decreased breath sound suggests your tension pneumothorax. Immediate decompression with the chest tube is required. All right, and you're always gonna decompress on the affected side. All right, so wherever you have the tension been building up on, that's the side you're gonna decompress. All right. My bad. Hold on. All right, so that's where we're gonna be doing all of that. All right, let's go up to. All right, so you have a patient with receiving high dose of corticosteroids that develops hyperglycemia. Is that normal? If you have a patient that is on that is on corticosteroids, is that normal for them to develop hyperglycemia? Yes. All right. What is the nurse's best? Yes, Dorian. All right. What is the nurse's best action? A, monitor blood glucose and follow the provider's order. B, stop corticosteroids immediately. C, encourage fasting only, or D, restrict fluids only. All right, so A, nice. All right, monitor the blood glucose and follow the provider's orders. All right, so corticosteroids increase your glucose levels. Managing and monitoring of the hyperglycemia prevent complications like your DKA in diabetic and non-diabetic patients. All right, so you definitely want to go ahead and monitor that. All right. All right, we said this one already. We already did this one. All right, a patient with a septic shock has a blood pressure of 75/40 after fluids. What is the next priority? A, administer vasopressor as ordered. B, restrict fluids, administer antipyretic. D, encourage oral hydration. So you have a patient that is in septic shock and the patient's blood pressure is 75/40. What is the next priority? All right, so A, administer vasopressor as ordered. All right. What kind of drug is your vasopressor? Okay. It's a vasoconstrictor. Nice. All right. So if you have a patient that is on this medication, what are you gonna be monitoring for in terms of your assessment? What is something that you definitely want to make sure you're doing for these patients in terms of your assessment? Because what is happening? All right, so definitely, all right, blood pressure, heart rates, okay. All right. In terms of their skin, are their extremities, are you concerned about anything with their, their fingers, their toes, their lips? Will you be monitoring anything like that? Pallor, okay. Color and temperature, okay. Okay. All right, so definitely want to keep an eye on their, their extremities. All right, you want to keep an eye on their extremities there. All right, look at their capillary refill time and all, because you might have poor perfusion because of the vasoconstriction that is taking place. Because just remember, the body is compensating. The body is going to be compensating. So if the blood pressure is low, you give them a vasoconstrictor medication, yes, you're gonna have tissue necrosis. So make sure you're keeping an eye on their fingers, their toes, to make sure it's not looking blue, cyanos, and then having necrosis taking place. All right, so keep an eye on their fingers and on their toes, lips as well, their ears, all of those places, because the body is basically focusing on the heart. All right, yes, or the major organs. All right. All right. Would you restrict fluids for this patient? Would you restrict fluids for this patient? No. No. You want to go ahead and make sure this patient is getting adequate amount of fluids. All right. Those IV fluids. Definitely. All right. Antipyretic, you'll definitely go ahead with that. Oral hydration, it depends on what's going on with the patient, all right, regarding oral hydration. But IV fluids, definitely you want to go ahead and make sure that you're giving adequate amount of IV fluids. All right. Persistent hypotension despite fluids indicates the need for vasopressors to maintain perfusion and prevent organ failure. All right. Where do you anticipate this patient going? Where would this patient go in? Med surge, patient will be staying in like a step down ICU. ICU where? ICU, nice. Septic shock may present with low temperature though. Yes. Refractory hypertension, use vasopressin. Okay. Yeah, so definitely we're anticipating this patient to go into ICU. Do you still administer antipyretic when hypothermic? No, 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 no. If a patient is hypothermic, you wanna need to go ahead with your your antipyretics. All right. Not a problem. All right. So gloves and gown for contact precautions. Temperature can be low or high, right? For yes, because sometimes they can have patients who is in like shock and they don't have a fever. All right. Sometimes they say it's called cold sepsis. Yeah, so not all the time they might have a fever. Not even exactly. The temperature is not even a priority. Perfusion is nice. Nursing student Avenger, welcome. Welcome. All right. Immunocompromised, yeah. All right. So a patient is on contact precautions for MRSA. Which action is correct? I think you guys said it already. You know, A, wear your gloves and your gown when entering the room. Use surgical mask only. No PPE is required. Airborne precautions are sufficient. All right, so you guys did say it. Wear the gowns and the glove when entering the room. All right. And we know those already. Okay, and I think we answered this one as a part of another question earlier. A patient with renal failure has a potassium level of 6.9. Which intervention is priority? Administer. Yes, the word only makes it wrong. And as I said before, anytime you see the only as a part of the option, always just eliminate that because there are other things you can do. All right. A patient with renal failure has a potassium level of 6.9. Which intervention is priority? A, administer calcium gluconate as prescribed. B, encourage oral potassium. C, increase potassium in the diet. D, document and monitor only. All right, so C is there. Administer calcium gluconate as prescribed. Nice, nice, nice. All right, so which and why do we administer the calcium gluconate? Why do we administer the calcium gluconate? Yes, to stabilize the cardiac membranes, definitely protect the heart. Antidote protects the heart, stabilize. So why not calcium chloride? Why not calcium chloride? Someone is asking to close the calcium channels on the heart, stabilize the cardiac muscle, and raises the threshold potential of the heart. Definitely. All right. So is there a significant difference between using the calcium gluconate and the calcium chloride? Yeah, my tummy. Is there a major difference in using calcium gluconate versus the calcium chloride in hyperthermia? Not hyperthermia, hyperkalemia. I don't think there is any significant difference. Okay, Nursing Avenger says yes, big difference between the chloride. Okay, all right, thank you for that. Let me look up something. There is, I'm not sure, my book says calcium gluconate. Yeah, I know both of them stabilize the heart because they're calcium, the root given. All right, so Nursing Avenger is gonna type it in. Gluconate is the safest. Okay, all right. So gluconate is more stable. Gluconate is safest. Okay. When will you be live next? Next week, Tuesday. If I guess if the turnout works better with calcium. Okay. Samina want go our bed. Yes, it was the last question. All right, so I'm gonna try to come back on Monday. So if I have this amount of turnout on Monday, then I will probably just run it through the week at 7 p.m. But we'll see how it goes. All right. BNC automatically eliminated. You skip one. Oh, so you need another one? Totally understand you, mademoiselle. Bluebird. All right, let's go here. So calcium gluconate is prescribed. So hyperkalemia in renal failure is life-threatening. Calcium stabilizes the cardiac membranes, while other treatments lower potassium levels. All right. So Bluebird, you want more? Okay, I can do more. So whoever wants to stay, I will be here. All right, as I say, I'm not working tomorrow. All right, I'm not working tomorrow. So I don't have a problem staying and finishing the 100 questions. The other persons that are going to be going to bed, then definitely, yes. So go ahead and tell me if you want to stay. So go ahead and tell me if you want to stay. If I have 10 persons saying that they want to stay, I will stay up with you guys and finish the questions. Otherwise, the entire live will be on YT on my page. So you can definitely go over there and you can definitely go over there and subscribe and watch the videos. All right. We also did cardiovascular system questions. We also do a lot of hold on a minute. Hello. All right. All right. So I did the cardiovascular. I also did neuromusculoskeletal. We did a few. And then from there, no, so Samina, I'm not coming live tomorrow. Tomorrow is Friday evening. All right. So I'm not going to be doing any live at 7 p.m. tomorrow. So I know you want to stay and I know you want to sleep at the same time. All right. So, I will definitely, let me see how many persons did put the word stay. Okay, so they say stay. So I'm just going to hang out, all right? But as I say, just tune into my other page and then you can always finish up with that. So I was always doing live at 7 p.m. on Tuesdays and Thursdays. All right. Yeah, challenge. Yeah, UWorld. I think I probably need to get that. Amora. All right, and then from there, I probably need to get that one, and then from there. But as I say, the studying, it's more, just studying and understand the concept, looking at the rationals, study a little bit broader, and then from there, swears by Saunders, cause it's affordable. Our school just got us UWorld, honest to my professor. Okay. They're really good too. Okay. Yeah, so it's more to just, make sure we're getting the concept and, understanding the rationale behind some things that we've been studying, and that's about it. All right. And as I say, these are not NCLEX questions. Nobody really has NCLEX questions that are definitely from, NCLEX world itself, but they have similar questions. And once you understand the concept, look at keywords and things like that. That's the most important thing. I am not just getting the questions for the exam. It's so weird. You have to understand the concept, all right? It's not all about just reading. You have to understand the concept, the content itself, all right? And then from there, try to answer the questions. But you have to look at keywords in the questions and try to make sure that, yes, that's on all subject. Okay. All right, and then from there, try to answer the questions as best as possible. Bluebird. I wish my Bluebird come from. How about you do them by subject areas? Okay. All right. Yes, as I say, I was doing them based on Central Standard Time. So 7 p.m. Central Standard Time. So I was doing them based on system just to go through. I was planning on doing some pathophase, just some pathophase questions, so we can actually just kind of work on that as well. And then from there. All right, but suggestions are well taken, so you can always send over and let me know. All right, when are you struggling when you are struggling on a topic, what I find works for me is going and reviewing that topic. Yes, definitely. Oh, it's currently 12:18 my time. All right, next question. Amora. All right, so let's finish up the question. The folks need a question. They definitely need their question. All right. So let's move on to the next question. All right. So a patient with myocardial infarction develops sudden shortness of breath and frothy pink sputum. Which condition is likely? A, acute pulmonary edema. B, pneumothorax. C, pulmonary embolism. Or D, pneumonia. So a patient with myocardial infarction develops sudden shortness of breath and frothy pink sputum. Which condition is likely? All right, acute pulmonary edema. All right, pneumothorax, pulmonary embolism. So we have A, nice. All right. So left-sided heart failure after MI can cause fluid accumulation in the lungs, presenting as dyspnea and pink frothy sputum. Okay, so that means there's an RCA involvement. All right. So nursing student Avenger. I need to look on your page. Okay, so you can also follow Nursing Student Avenger as well. All right, folks. Helps you ace nursing school and NCLEX. All right, so you can join the community for Nursing Student Avenger. So the key word in that is the pink frothy sputum. All right. Yes, so definitely. Oh, you guys know about him. All right. So definitely look at that. All right. And we know about the pneumothorax. We know about the pneumothorax, the pulmonary embolism. All right. And the pneumonia. All right. And then we talk about, so the left-sided. Pull this back down. All right. So there is the question. All right. The right coronary artery. Okay. Right coronary artery, the RCA. All right. Alrighty. So a patient is receiving digoxin and furosemide. Which finding is most concerning for that patient? All right. Is it A, the serum potassium of 3.0, B, mild fatigue, C, slight ankle edema, or D, blood pressure of 130/80? All right, hypokalemia, AAA. Okay, nice. Why are you concerned about the hypokalemia for this patient? Why is that one most concerning for you? Okay, diuretics, they can lose more potassium, increases the risk of toxicity as well. All right. Risk for arrhythmia, so increasing the toxicity. All right, so the hypokalemia increases the risk for digoxin toxicity, and that is life-threatening as well with their arrhythmias. All right, so you definitely want to make sure you're very, very careful when you're doing your administration. For your digoxin, what is very important? What is very important for you to check before administering your digoxin? What is something that you need to check before? Okay, nice. All right, so you want to check your heart rate before you're administering your digoxin. All right. All right, eventually, yeah, your digoxin level. All right. If you notice you've given this patient too much digoxin, how do you counter that effects? What is the reversal medication for that patient? Digibine, okay, okay, all right, nice, yes, all right, Digifab, all right, so let's move on. So a patient with peritonitis reports IV fluid. Sorry, I don't know how to spell. That's fine. We get the picture over here. All right. A patient with peritonitis reports rigid abdomen, severe pain, and a fever. What is the nurse's priority here for this patient? A, notify provider immediately, encourage oral fluids, provide analgesics only, and apply heating pad. Rigid abdomen isn't good. So you notify the provider immediately. Okay. All right. Why you gonna notify the provider immediately? What are you concerned about? Like, what's the plan? Don't encourage more fluids. All right. Infection, yes. All right. So the patient has peritonitis. So you're anticipating this patient to go, okay, surgery, NPO, nice. All right. Severe pain and infection. All right, so peritonitis can lead to sepsis and shock. So prompt evaluation and interventions are critical. All right. All right, so, all right. A patient with hypocalcemia, all right, reports tingling in the fingers and a positive chopstick sign. Which intervention? Oh, which intervention is priority? They need calcium, definitely. They need their calcium. Hypocalcemia. All right, so administer the calcium as prescribed. Encourage high phosphate diet. Provide bed rest only or monitor blood glucose. All right, so definitely they need their calcium. What EKG findings are you anticipating for this patient? What EKG findings you think would be present for a patient with low calcium? Yes, Benny. Yes, Benny. Just pulling our memory a little bit. Are we thinking about any EKG changes for a patient with a low calcium and prolonged QT? Nice. Okay. All right. So you can have your T wave inversion. Sometimes they have the torsades de pons. All right. All right, but the prolonged QT interval was pretty common. All right. Torsades de pons is a life-threatening condition, especially when your potassium is low. All right. So it's a life-threatening arrhythmia. Okay. All right. Not a problem, Camila. Thank you for tuning in. All right. All right, so definitely you want to go ahead and administer your calcium as prescribed. Give magnesium sulfate for your torsades, definitely. All right. So hypocalcemia can cause neuromuscular excitability and tetany. Rapid calcium replacement is necessary to prevent complications. All right. All right. So you have a patient with CHF that is prescribed a beta blocker. Which statement indicates understanding? I will check my pulse before taking the medication. I can double the dose if I miss one. I will immediately relieve my shortness of breath. Or D, I can stop if I feel tired. So you have a patient that is a CHF, okay, and the patient is prescribed a beta blocker. Which statement indicates understanding? AAA, I will check my pulse before taking the medication. All right, nice. What are some examples of your beta blocker? Atenolol. Okay, nice. Propranolol, metoprolol. Nice. All right. All right. And apart from the heart rate being lowered or decreased, I'm nursing. What are other effects, you're anticipating from your beta blockers? Low blood pressure, decreased blood pressure, okay. Bradycardia, they can cause what else? Bronchoconstriction, orthostatic, okay. A mask hypoglycemia, nice. All right, so you have to be careful with your asthma patient and your diabetic patients. All right, nice. Erectile dysfunction. All right. So I can double dose if I miss one. No, do not give to asthma patients. Okay. BPH. All right. Low libido. Okay. All right. I can double the dose if I miss one. No, we're not gonna double up on no dose. All right. This will immediately relieve my shortness of breath. No, I can stop if I feel tired. Definitely not. So I will check my pulse before taking the medication is the most appropriate thing because beta blockers can cause bradycardia. All right. And if you see this on a question, always remember that this is one of the medication that you have to do something before administering. All right. So if the heart rate is below 60, you definitely withhold it. And then from there, you let the provider know. All right. So patients should monitor pulse and report symptomatic bradycardia. All right. All right. Uh-oh, goodness. Not given, not 100% sure though. That always confuses me. Which one, Starry? You just have to be careful with your asthma patients. You have to be very, very careful with them. All right. A patient with DVT is prescribed Lovenox. Which instruction is most important? A, avoid massaging the injection site. B, take vitamin K supplements daily. C, stop walking until therapy is complete. Or D, apply warm compresses only. It's contraindicated with asthma. Yeah. All right. C, stop walking until therapy is completed. All right, so which instruction is most appropriate? I see a few A's and I see one C. All right, and somebody says B. All right, avoid massaging the injection site. All right, because you're going to be risking bleeding there. All right, so massaging the sites increase the risk of bleeding and bruising. Enoxaparin is administered subcutaneously, usually in the abdomen, and precautions reduce complications. So no massage at the site. All right. I see somebody had said to stop walking until therapy is complete. Do we encourage them to stop walking? Are they on complete bed rest? Are these patients on complete bed rest? Nope. All right, definitely. All right. All right. A patient with hyperthyroidism is prescribed propylthiouracil, PTU, which lab requires close monitoring. All right. You want them to walk. Which lab requires close monitoring? Is it the white blood cell count, hemoglobin only, C, the blood glucose, or the sodium level? So a patient that is on PTU, patient is a hyperthyroidism patient, which lab requires close monitoring. Let's see, AAD, white blood cell count. All right, definitely. All right, your white blood cell counts because it causes agranulocytosis, increasing infection risk. Patient should report any fever or sore throat promptly. Yes, they're highly at risk for infection. All right, so you want to make sure that you let them know what to report. And as I say, the one with the only is, you take that one out and then you have the others to kind of play around with and then decide from there if you're still struggling with the answer. All right. A patient has attention pneumothorax, which finding is most concerning. Tracheal deviation away from the affected side, mild dyspnea, cough with sputum, slight chest discomfort. Okay, that definitely the tracheal deviation away from the affected side. Okay, nice. All right. Now we say we use the needle to do what? You're anticipating this patient to get a chest tube, or you can use the needle to decompress as well. All right. The mild dyspnea is expected. Cough with sputum. Are you expecting any cough with sputum for this patient? Potential pneumothorax? No. Okay. Nice. Not expecting a cough with a sputum. Some Brar says yes. Okay. Does it have any color though, or it's just like, you know, regular clear sputum you're thinking? Yeah, so A is the correct answer. All right. They'll have the chest discomfort. All right. They'll have the chest discomfort. But the one that is most concerning is the tracheal deviation. All right. So the tracheal deviation away from the affected side. All right. Tracheal deviation indicates high intrathoracic pressure comprising cardiopulmonary compromising cardiopulmonary function. Immediate decompression is required for this patient. All right. A patient with COPD has a PaO2 of 55. Which oxygen delivery method is safest for this patient? So you have a low flow nasal cannula, non-rebreather at high flow, simple mask at 10 liters, high concentration mask for extended period. Okay, all right. How much are you anticipating in terms of oxygen for this patient via your nasal cannula? How much are you anticipating for your COPD patient in terms of oxygen flow? Around 2 to 3 liters. Okay, nice, Benny. See, Florical says non-rebreathe at high flow. All right. Remember, this patient is a COPD. Florical. All right. So you don't want to put this patient on too much oxygen. Over oxygenation decrease their need to breathe. Okay, nice. All right. So it's A. All right. So you want to get them on the low. If you wanted to get them on a specific, like a control, if you want to control the amount, so for example, you know, you want to give them this amount of oxygen, which of them would you? Okay, so the Venturi mask, lead innovation. You definitely would put them on the Venturi mask for that specific amount that you want. All right, you set the rate. All right, so the low flow nasal cannula. Yes. So the low flow nasal cannula, the COPD patients rely on hypoxic drive. High flow oxygen can suppress respiratory effort. Low flow oxygen maintains safe saturation without risking CO2 retention. All right, so if you had Venturi mask there, you probably could have chosen that one. All right, they trap air and retention of too much carbon dioxide. All right. All right. All right, a patient that is on heparin has platelets dropped to 80,000. What is the nurse's priority action? All right, so you have a patient that is on heparin and the platelets has, because you can actually set to, for the Venturi mask, you can actually set the amount of oxygen that you want. So it risks the patient getting too much oxygen. All right, so if you know you definitely need this percentage, you can always just go ahead and set that amount. All right. All right. So A, stop the heparin and notify the provider. All right. So heparin-induced thrombocytopenia is what you're trying to prevent. So this patient is having a serious complication. So you want to definitely go ahead and discontinue the medication and monitor them. All right. All right. So if you have a patient that is on heparin, what lab value are you monitoring? PTT. Okay. You're definitely monitoring your PTT. Who are you monitoring for your INR? You definitely for your PTTs for your heparin and your warfarin is for your INR. Nice. Okay. All right. Okay. A patient with type 1 diabetes, warfarin for INR or PT for warfarin. Okay. Yes. You have a patient with type 1 diabetes that presents with Kussmaul respiration, all right, and fruity breath. Which lab result is most expected? Elevated blood glucose and positive ketones, a low blood glucose, normal glucose, low ketones. Okay, AAA, the elevated blood glucose and the positive ketones. All right, so what condition are you thinking this patient is having? Definitely, Benny says DKA. All right, what's the giveaway here for this? Why you say it's DKA? The fruity breath, okay, nice. And the ketones, definitely. All right, so even if you never get the urine or you never get the blood, the blood results to see exactly what's going on, and you notice the smell and the breathing, then definitely you know that this patient, especially with their diagnosis, that patient is in DKA. All right. So elevated blood glucose and positive ketones, nice. Ketones show up in DKA. Yes, it does. All right. Okay. So they're not going to be having low blood glucose. They're not going to have normal glucose, and their ketones are definitely not going to be low. All right. So elevated blood glucose and positive ketones. So Kussmaul respirations and fruity breath are classic signs of diabetic ketoacidosis. Lab findings might include hyperglycemia and ketonemia. All right, and that is a medical emergency. All right, so you get your IVs and you get a lot of fluids for this patient going, and get your EKG, get the patient on a cardiac monitor, look at their potassium level, and then you start your infusion. All right. A patient with a new colostomy asks why output is liquid initially. What is the best response? A, the stool consistency will change as the bowel adapts. B, you should expect solid stool immediately. Liquid stool indicates infection, or diet has no effect on stool consistency. So a patient has a new colostomy, and they ask, about their output, why it's liquid initially. Definitely, it will eventually change based on their bowel, how their bowel is adapting. All right. Just like our babies or neonates, once they're born, it's very watery, and as soon as they start introducing food, it starts, changing the consistency, becomes pasty, then it, semi-formed until, eventually become formed. So newly formed colostomy produce liquid stool initially. Consistency becomes more formed as the bowel adapts over weeks. All right. All right. So a patient with MI develops sudden hypotension, muffled heart sounds, and jugular vein distension. What are you thinking in terms of diagnosis for this patient? What's the giveaway there? Okay. AAA, notify the provider. Okay, for possible cardiac tamponade, everybody's saying yes. All right, so you need to know the different fluid overload. Okay, yeah. The muffled heart sound. Right-sided heart failure. All right, so the muffled heart sound, the hypotension, the jugular vein distension, definitely for your cardiac tamponade. All right. So what is the priority is to notify the provider of the possible cardiac tamponade, provide analgesics, encourage ambulation, monitor vital signs only. Now notify the provider, and then from there, all right. Beck's triad, all right. So Beck's triad, hypotension, muffled heart sounds, and the JVD indicates cardiac tamponade. It's a life-threatening emergency requiring immediate intervention, all right. Oh, we did this question earlier. Pericardiocentesis is needed, definitely. So you prep this patient in the meantime for that procedure, all right, so patient is receiving IV vancomycin. Yes, IV vancomycin, which intervention prevents red man syndrome. A, administer over 60 minutes. B, administer rapidly for efficacy. C, give with oral IV antibiotics simultaneously or stop monitoring vital signs. So we say A, which is to administer over 60 minutes. And we're saying what lab value will you be monitoring for this patient that is getting vancomycin? So what lab value are you concerned about for this patient before you give it? Yes, so slowly give it. Okay, so white blood cell count, peak trough, I think. Okay, BP. Okay, what organ, BUN and creatinine? Okay, definitely. But out of the BUN and the creatinine, which one of them are you mostly concerned about? Okay, yeah, the kidney. But so BUN and creatinine, which of them? The creatinine, definitely. All right, the creatinine, because we know that this medication, vancomycin, tend to cause what? It's nephrotoxic. All right, so we need to know the drugs that are nephrotoxic, ototoxic, things like that, and what lab value we need to monitor for the exam. All right, yes, so nephrotoxicity, definitely. All right, so administer rapidly, definitely not. Give with other antibiotics simultaneously, no. Stop monitoring vital signs, no. All right, so Redman syndrome, you administer over 60 minutes, slowly. All right, and that is characterized by the flushing, the hypotension, and the rash. Okay. A patient with CHF is prescribed spironolactone. What kind of medication is spironolactone, or what's the class of drug for spironolactone? Potassium sparing. Okay. What's the class? It's a potassium sparing diuretic. Okay. All right. So which lab? So we say AAA, serum potassium. All right. Sodium only, calcium only, magnesium only. All right. So we all say A. It's a potassium sparing medication. Hyperkalemia is a risk, especially heart failure and renal impairment, aldosterone receptor. Okay, nice. All right. All right. A patient with COPD reports worsening dyspnea and barrel-shaped chest. what complication should the nurse suspect? So you have a COPD or patient who reports worsening dyspnea and barrel-shaped chest. What complication should the nurse suspect? A, chronic hyperventilation of the alveoli. B, pulmonary embolism. C, pneumonia. Or D, pleural effusion. Okay. All right. So chronic hyperinflammation, inflation of the alveoli emphysema. Definitely. All right. So barial chest and progressive dyspnea are classic signs of emphysema, a type of COPD resulting from alveolar damage and air trapping. How do you differentiate emphysema from your chronic bronchitis? How do you know which one is which one? How do you tell the difference? Bronchitis as a cough and a sputum. Okay. All right. So bronchitis can be acyanotic and has dyspnea, definitely. So you know about the blue and the red. Emphysema is pink color, definitely. So emphysema is pink, so the person tends to be looking really, really pink. All right, because what's happening with them? The blue bloater, okay. All right, so blue bloater, bluish red skin, and the chronic productive cough for your bronchitis. Okay, nice. And then for your emphysema, they're looking pink, blue bloater for broncho, and pink for your emphysema. All right. So you tend to have so for your emphysema, they tend to have the sputum. All right, so for your emphysema, they tend to have the severe dyspnea. They tend to have the quiet chest. All right, and they tend to have hyperinflation and the flattened diaphragms. All right. So they have destruction of their air spaces there going on. And those are the ones that are considered to be pink. You have the shortness of breath. And then you have the chronic bronchitis. They have the cough, and usually the cough is daily, it's productive. All right. They tend to be a little bit more overweight and cyanotic, so they are usually blue, all right, because they have a lot of hemoglobin there, elevated hemoglobin. They tend to have peripheral edema, and those patients tend to have a lot of rhonchitis and wheezing. All right, so let me just pull up this. All right, so for emphysema, you have damage to the tiny air space, the alveoli in the lungs, leading to their destruction and loss of elasticity. Bronchitis tend to have the inflammation and thickening of the airways, resulting in excessive mucus production and narrowing of the airway. All right. So why they have the blue and the pink is because for emphysema, all right, they have the shortness of breath, especially during exertion, wheezing, barrel chest, and the pink complexion. Oh, I'm trying to find the... Okay. All right, so for... I'm trying to find something here. There's a way to remember it. All right, so for the chronic bronchitis, they tend to have the persistent productive cough, shortness of breath, wheezing, bluish tint to the skin because they're cyanosed. Shortness of breath, blue water broncho. All right, so I'm trying to look up something here. So with emphysema, all right, you have the air sac supply oxygen to the blood. So with damaged air sacs, there is less oxygen can enter the blood. All right, and that's how they tend to become pink. The chronic bronchitis, you have the destruction of their tiny hairs called cilia in the airways of the lungs. The airway then become inflamed and narrow, making it difficult to breathe, and so you tend to have them become cyanotic. All right, so that's how they say that they're pink and blue, because one is trapping air and one is the oxygen is there, but the putamen blocks the airway. Okay. All right, so it's like they're not, one is not a, and then you tend to have one do a lot of pursed lip breathing, and the other one is without the pursed lip breathing. Emphysema is the gaseous exchange is impaired due to alveolar destruction. All right. All right. I'm feeling the sleep coming over me. All right. A patient taking lithium reports nausea, vomiting, and tremors. Which action is priority? All right. And we did a question like this earlier. Notify the provider for possible lithium toxicity. B, encourage hydration only. Continue medication and as prescribed and reduce dietary supplement sodium. All right. So we say A because we're thinking about lithium toxicity. All right. So if the patient is on lithium, they're having nausea, vomiting, and tremors, the priority is to notify the provider. When you notify the provider, what are you thinking about? Next, you notify the provider, you plan on getting your blood values to look at your levels, right? All right, so you make sure you get your lab values to see exactly what's going on. So these are signs of lithium toxicity. Prompt evaluation and dose adjustment prevent serious complications. So you want to know what their lithium levels are. So you stop the medication, you know what the lithium levels are, and then from there they can always go ahead and adjust the medication. Lithium toxicity is nausea, tremors, ataxia, and confusion. Nice. All right. So you have a patient with hypovolemic who is having hypovolemic shock, but the patient is receiving fluids, which finding indicates improvement. A blood pressure of 110/70 with a heart rate of 90, blood pressure 80/50 with a heart rate of 130, weak peripheral pulses or decreased urine output. Okay. A, definitely. All right, those are normal vital signs. 80/50, the patient is still hypotensive. Patient is still tachycardic at 130. Almost normal vitals, yes. All right, weak peripheral pulses. No, you don't want the peripheral pulses to be weak. You want them to be strong and bounding. And decrease urine output. No, you don't want to decrease urine output for the patient. All right, especially if they've gotten a lot of fluids. All right, so definitely your 110/70 would have indicates that the patient is improving in terms of the vital signs. B, still compensating. Okay, yes. All right, because of the shock. All right. If it is improving, you shouldn't see wave pulse. You shouldn't have weak pulse and decrease, definitely. All right. You don't want that. So rising blood pressure and decrease in heart rate indicate improvement, improved perfusion and response to fluid resuscitation. All right, so you want the vital signs to be trending the opposite direction. So if they were at a 70, you want it to be going 80, 90, you know, the numbers to get a little bit higher. All right. We did this question already. Patient with chronic renal failure has phosphate of 6.2. Which intervention is appropriate? Administer your phosphate binder with meals. Encourage high phosphate foods. Restrict fluids only. Administer potassium supplement. A, definitely your phosphate binder. All right, you definitely want to do that one. All right, so phosphate binders reduce absorption of dietary phosphate, preventing complications like secondary hyperparathyroidism and bone disease, to stop the phosphate from elevating, definitely. All right. Lord. Goodness, sorry. A patient with heart failure reports orthopnea and paroxysmal nocturnal dyspnea. Which intervention is priority? Assess first, okay, nice. Elevate the head of the bed and assess priority and assess respiratory status. B, encourage fluid intake. C, administer high sodium diet or provide routine analgesics. Definitely, you want to go ahead and elevate the head of the bed, all right? And remember the key words, you know, priority. What intervention is priority? Always you look at those words, priority first, you know, delegation, things like those. So elevate the head of the bed and assess your respiratory status. Don't give anything without assessment. Definitely Amora, all right? Never give anything without assessment. C is definitely out. Administer high sodium diet. Yeah. All right. And so once you understand pathophys and all, you know, you'll be able to better answer the question as well. So that's another thing. All right. So administer high sodium, definitely out. So use the process of elimination. Always look at your Maslow's hierarchy of need. You use your nursing process, the ADPI, and you also use your airway breathing circulation. And then sometimes, you know, you might have to change depending on what is going on neuro-wise. All right, but if oxygen is a problem, that is always going to be priority. All right. All right, so upright positioning improves ventilation and oxygenation in patients with pulmonary congestion and dyspnea. All right. Okay. You have a patient that is taking ACE inhibitors, developing persistent cough and angioedema. What is the priority action for this patient? A, notify the provider immediately. B, encourage fluids only. C, provide cough syrup. D, reduce dose without provider's orders. Yes, definitely. All right, angioedema is a emergency, so that needs to be taken care of immediately. All right, so notify the provider, and then from there, discontinue the medication if they're developing angioedema. All right, so discontinue that medication, and then from there, encourage fluids only. No, definitely out of it. All right, because this person's airway is at risk, so you want to make sure you don't give them anything. Dry cough is okay, not persistent cough. Definitely lead innovation. All right, and usually if they have the cough, you know, usually try to titrate them off the medication, not stop it immediately. Try to titrate them off and get them onto another medication. Provide cough syrup, definitely not right now. Reduce dose without provider's orders, no. All right. Oh my word, why am I always doing this? Oh, all right. So ACE inhibitors can cause angioedema, potentially life-threatening reaction. Immediate evaluation is required. All right. You have a patient with hypomagnesemia that is receiving IV magnesium. Which finding requires immediate intervention? Is it A, respiratory depression, B, mild tremors, C, fatigue, or D, nausea? So a patient that is on magnesium and the patient develops hypomagnesemia, which finding requires immediate intervention? Airway breathing circulation. Okay, respiratory depression. Nice, lead innovation. All right. Mild tremors, fatigue, nausea, A. All right. So hypermagnesemia from rapid IV administration can cause respiratory depression, hypotension, and cardiac arrest. All right. Continuous monitoring is essential. All right. So be careful when you're giving your magnesium. All right, a patient with asthma has nighttime wheezing and frequent rescue inhaler use, which action is priority? All right. A, notify provider for step-up therapy. B, encourage walking, continue current regime only, or document and monitor. So you have a patient that has asthma, and the patient is having nighttime wheezing and frequent rescue inhaler use. Which action is priority? They need better control, so you're gonna get them a step-up therapy. All right. So frequent nighttime symptoms and rescue inhaler use indicate that they're poorly controlled. All right. So asthma. So it requires adjustment to their therapy. So C is good, but it uses the word only. Yes, continue current regime only. You need to add something else to it though. Lead innovation. I need something else because if they're gonna continue the current regime, they're still gonna be having the nighttime wheezing. All right. They're gonna be having the nighttime wheezing, so they're still gonna be poorly controlled. So they need some adjustments to their regime. All right. Maybe corticosteroids. Yeah, they can be getting that. Can be getting some more steroids. All right. A patient with CHF reports ankle edema and weight gain. Which lab value or which lab or assessment is priority? You have a patient that has CHF reporting ankle edema and weight gain. Which lab or assessment is priority? Okay, daily weight and electrolytes. Okay. All right, blood glucose only. I'll just say all these with the only there is just like distractors, so just ignore them and then work on the other options that you have. All right, so this patient has ankle edema, weight gain, so patient is having, fluid retention, so you want to make sure you're looking at the electrolytes. All right, and do their daily weights. All right, because more than likely they're having worsening in terms of their heart failure. How will you know if their heart failure is worsening? What lab can you do for this patient? What lab can you do for this patient to see if their BNP? I was looking more for your BNP lead innovation. All right. I was looking more for your BNP for your CHFers. So troponin is more specific for who? The troponin is gonna be for which patients? Your MI patients. Nice. All right. Yeah. All right. For your MI patients. All right. And then let's see this one. You have a patient with acute pancreatitis that reports severe abdominal pain and has elevated serum amylase. Which intervention is priority? All right, so you have a patient with acute pancreatitis reporting severe abdominal pain and elevated serum amylase. Which intervention is priority? NPO status and IV fluids, encourage oral feeding, provide antacids only, administer high-fat diet. All right, A. All right, A, definitely want to keep this patient NPO. All right, you're not going to put too much work on their pancreas. All right, so you're going to keep them NPO, give them IV fluid. And as we had said before, let's see, what is this patient at risk for? Hyperglycemia or hypoglycemia? NPO because you don't want to put pressure on the pancreas anymore. Definitely. All right, so what is this patient at risk for? Hyperglycemia, hypoglycemia. Hyperglycemia. Why hyperglycemia? Pancreatic pancreas, hyper and hypocalcemia. Pancreas, okay, so maybe hypoglycemia. So it's more hypoglycemia. So this patient is going to be at risk for hypoglycemia. All right, not hyperglycemia. All right, due to the insulin from the beta islets. Yeah, due to lack of insulin. All right. So definitely this patient is going to be at risk for hypoglycemia. So you have to monitor this patient carefully. All right. So fasting reduces pancreatic stimulation. And then again, you know, the patient's not going to be eating as well. So that is even going to worsen their glucose level. All right. So fasting reduces pancreatic stimulation, and IV fluids prevent dehydration and maintain perfusion. All right, pain management is also important for this patient. All right, but definitely you want to go ahead and keep this patient NPO, IV fluids. Probably going to end up giving this patient some IV with some dextrose, saline, things like that, because of the risk for hypoglycemia you want to try to prevent. All right, and then from there, oh Lord, that was a handful. Fargo vibes, welcome, welcome, welcome. You're still up. All right, but it was a nice, you know, run tonight. All right, it was a nice run tonight. Thank you so much for tuning in. All right, and you should definitely try UWorld for the questions. Definitely, I'm gonna look at it. I'm gonna definitely look at it. Amora, who said it? Amora. Yeah, I'm gonna look at it. I recently just started these, so I didn't want to, you know, try something and then that was just it. Yes, I will definitely see you US4 live on Tuesday. All right, or Archer. Okay, or NCLEX boot camp. That's let me look at something here. Okay, so NCLEX. So initially when I saw the NCLEX boot camp, I thought you guys wanted me to do a boot camp. Okay, so NCLEX boot camp. Okay. Okay. Okay, I'll take a look at them, and then from there, I'll take a look at them and look at which one is gonna be best. And then from there I can try that. Thank you guys. Thank you guys. Not a problem. Yeah, I just started probably a couple of weeks ago. I always wanted to do it on my YT page, but I realized I was getting more traction over this side. So I'm streaming on both platforms. So just in case persons are not, you know, able to make it to the class, then they can always go over to my YT page and get the full live. So definitely, so I'm definitely always going to be here on Tuesdays and Thursdays. All right, and I'll try to get the things set up a little bit better. All right, but Tuesdays and Thursdays were the days I was doing my NCLEX or study session. We were doing the little study session. But seeing that we have so much persons out, like, you know, this is the first time I'm doing it. And it was Carousel. Oh my goodness, I must thank Carousel for telling me, like she told me about, you know, putting up the questions. And this worked tonight because usually I'll be there talking. You understand? Usually I'll be there talking myself away, reading the questions. And she suggested, or as I say, I don't know Carousel is a male or female yet. Carousel not answer yet. You understand? Suggesting I put the questions up. And I tell you, I never expected to see so many persons. You understand? I never expected to see so many persons tonight. So it was really worth it. And that's just it. More interaction on here. Okay, nice. Nice. Yeah, that's what I wanted. I didn't want it to be a case where we're just reading the question and just leaving it there, you know. I wanted to kind of just pick your brain a little bit more. Just wanted to pick your brain a little bit more, and then from there. So can you please explain why pancreatitis causes hypoglycemia? Because of the glucagon. So remember, you're gonna have the pancreatitis causing, like, the damage to the cells, and that's where you have your glucagon. So you're gonna have the patient being at risk for hypoglycemia, because if you don't have any glucagon storage there, this patient is gonna be hypoglycemic because the pancreas is already damaged. You have the inflammation taking place there. All right. So that's the reason why you're gonna be having your patient becoming hypoglycemic, because they're gonna be low on their glucagon. Tuesdays and Thursdays at 7 p.m. Central Standard Time. So I'm in Texas. So my time now is 12:13. All right. Thank you for sharing up the live, love, Evie. All right. So my time is 12:14 now. All right. So it's Central Standard Time. I'll try to be good with scheduling the live so persons can see. I'm still a little bit new to social media or TikTok in a sense. So yeah, I'm not up there as yet with the TikTok vibe. All right. I'm still learning TikTok. So that's just it. All right, but it was nice having you guys here. Not a problem, Eko Marie. All right, it's not a problem. You're welcome, no problem. So that's about it. Thank you, thank you, thank you for showing up. All right, thank you for showing up. So yeah, I'll try to fix up my little thing here, because as I say, it was Carousel who said, "Oh, go ahead and just put the questions up and whatever." So I found a little string, and I tell you, it took me about an hour to figure out how to get the questions up. But either way, I know that it wasn't 100% perfect, but I'm happy with the results because it was a really good. And the thing about the live, I love it because I'm learning as we go along. Yeah, and I'm never too old to learn. And that's the thing I really like about it. It's more of a refresher course for me as well. So thank you guys for, being so active on the live. I really appreciate that. Can you come up earlier, because it will be 8 p.m. my time zone. So you know that I spend a lot of time on the road. I spend a lot of time on the road, and because I do house call. So I spend a lot of time on the road, and then 7 o'clock is like the sweet spot. Sometimes I'm still running behind time, but 7 o'clock is a sweet spot for me. So I cannot, because it will be 8 p.m. for you. I cannot, it depends on the day. I can't guarantee that I'll be here for 6:30 or 6 o'clock, honestly. Yeah, because sometimes I have to try and take a little nap, because I know sometimes the live will go a little bit longer than the 1 hour, the 2 hours that I probably want to do on a Tuesday. So on Tuesdays, I'll try to see if I can do for 2 hours, but depending on the vibe. But if I have this amount of, persons, then we can always do, the 2 hours or probably 3 hours. Because I only work like 3 days a week right now. And then on Thursdays, I usually go a little bit longer depending on the vibes that I'm getting. So if the turnout is good and you guys are pretty interactive, then it is worth it. I don't have a problem staying up and, studying with you guys. I wish I had this kind of study session when I was doing my nursing program. Yeah. All right, then. Well, it was nice, chit-chatting with you. Thank you. Not a problem. Me too. US for life. Not a problem. Enjoy your night now and stay safe. Amora, I will definitely look into your U-World and the boot camp. You say it was NCLEX boot camp. Yeah, I'll look into those, and then from there, so we can actually make the questions a little bit more than option A. Oh my word, NCLEX boot camp. It's a bit pricey though. Oh my word. Okay, all right. Let me see what's happening here. Okay, let me see if I can afford it. U-World and NCLEX bootcamp. Okay, yeah, I'll look at them and then from there. All right, but anyways, enjoy your night, and it was nice having you guys on the live. Remember to go over to my YT page, all right, and subscribe. All right, and you can check out the other contents I share over there related to nursing, travel, lifestyle, and the whole 9 yards. All right, until then, I will see you in the next video. All right, bye. And remember to follow me. All right, remember to follow me. Search that on Shein for allowance with a new account. What's that? All right then. How do I close this again? Why am I not seeing the X button for? Oh, because I am over this side. Okay. Whoa. All right. And thank you guys for tuning in. All right. I really do appreciate you taking the time out to hang around on the live tonight. And whenever time you're watching it, I hope you learned something. All right. I hope you learned something from it. All right. Enjoy your night.